scrutiny of the 2026-27 municipal year. Before we start these proceedings, may I bring to your attention to some housekeeping matters. There is no expected fire alarm testing today. Therefore, if the fire alarm sounds, please follow the fire and emergency procedures that are applicable to the council house. This meeting will be broadcast live to the internet and will be capable of subsequent repeated viewing. By entering the Warspite room and during the course of the meeting, committee members are consenting to being filmed and to the use of those recordings for our webcast. Please can I ask that you speak clearly and directly into your microphone when addressing the meeting so that online participants and the public can hear, and that it is switched off when you are not using it. Your mobile devices are turned to silent. Now, what we're going to do is we're going to just go around the room today, because obviously we've got a few members that are new to this committee. We've got a few that were been on it actually for the last 2 years. So if we go around the room, in the room, and anybody that's online also. So I'm going to start. All right, so I'm Councillor Pauline Murphy, chair of this scrutiny committee. I've been chair now for the last 2 years, and the reason why I sit on this committee is because of issues that were brought to my attention a couple of years ago about adult social care, waiting times and all of that sort of thing. So I was really passionate to make sure that everybody got treated the way that they should be treated. So I'm going to ask you to introduce yourself and ask why you want to sit on this panel. So I'm going to start with you, Paul.
Hello, I'm Councillor Riley. I've obviously just come to the council. I'm interested in health and social care because I've been involved with health and social care for some time now, especially in community development, and spent about 25 to 28 years working with residential care and dementia, and I've also worked in a bit with mental health, especially with females.
Thank you.
Hi, I'm Councillor Carol Ney, Southway Ward. I've been on this panel for 2 years previously. I've got a background in nursing for over 26 years, and for me it's very important to promote the health of the wards and the city. Thank you.
Hello, I'm Vanessa Tyler. I'm standing for reform for Plymouth and St Mary Ward. I just, only because I've got a mother that's in her 80s, there's not a lot out there for the elderly, so I thought I'd just try and jump on this panel to see if I could do anything to help.
Can I just remind councillors that we're no political party in here, we're impartial, so we don't need to explain what political party we're with. So it's just who you are and why you want to be on this panel.
John Mahoney, Councillor for Plymouth Radford, retired GP. Health inequalities and access to healthcare have always been important to me, and I've served on this committee in my former lives.
Hello, Councillor Laura McClay for Plimpton Chadderwood. I currently work in social care. I'm a carer for an individual with a personal health budget. I have also volunteered for mental health charities in the past as well, so I'm just really delighted to continue to serve on this panel this year.
Hello, I'm Councillor Keith Moore of Honicknall Ward. I have no professional interest in being on this panel, but I have been a customer of the NHS in recent years a couple of times, and I was so impressed with the work that was done, certainly at Darrford, and how I was treated, that it made me quite interested in this subject, and that's why I'm here.
Good afternoon, I'm Councillor Ray Morton of Honicknall Ward. I've been on this panel for a couple of years now. I find it a particular interest. It kind of feeds into the role I was doing at Darrford Hospital as an augmentee for the Portering group that I work with up there. So I work for NHS professionals, and I worked up there when COVID was on, so that was really hard. And I'm particularly interested to see how we work in our communities and bring services to our communities and how we can improve them. So that's me.
I'm Councillor Noble for Moorview Ward. I have worked as a play worker and things in the past. I started working at Derriford during the pandemic as a cleaner, and I've continued to do that. So I suppose I've seen a lot of, first we saw the work through the COVID pandemic, and then I've seen a lot of the development over the past 2 or 3 years, and obviously seeing a new buildings redeveloped in my ward, and it's a very important part of the ward, so sort of that's where my interest comes from.
Good afternoon, I'm Councillor Alison Simpson. I represent Buzzhead Ward. I requested to sit on this committee because my background is in social care. I've done kind of so many things, sort of, I suppose mainly community based. Worked in mental health. I've done some work in the criminal justice system as well. Worked with elderly. Worked for social services, so I ask questions quite a lot about care packages and things like that. So, yeah, I guess social care is my absolute passion, and yeah, I'd go as far to say this is probably my favourite one to be on. So, well, yeah, it's the chair that does it.
The chair always does it. Good afternoon, everyone. My name is Councillor Anne Freeman from Dunport Ward. I was asked if I would like to sit on the board, on the scrutiny panel, sorry, keeps getting to me. I have background as unpaid carer at home for my mum, and also for my elderly nan, who's 104, and have a passion with, like us, and with care packages and finance side of things and everything. So, thank you.
Thank you. Lou Ford, I am the Service Director for Integrated Commissioning within Adults, Health and Communities. Thank you.
Hi everyone, I'm Julia Brown, Service Director for Adult Social Care.
Hi everyone, I'm Maria Lawson. I'm the Cabinet Member now for Health and Adult Social Care, Councillor for Plymouth Dunstan. Health and inequalities have always been a passion of mine, and I think to have a thriving Plymouth, we need a healthy Plymouth, and that's my motivating factor.
Hi, I'm Helen Slater. I'm Head of Finance. I spent several years actually as the Lead Accountancy Manager for Adult Social Care, so I know the budgets really well, which has really helped me as I've stepped up into a new role.
Hi, I'm Charlie Atkinson. I'm one of the Principal Democratic Governance and Scrutiny Officers.
Good afternoon, everyone. Elliot Werngold, also a Principal Democratic Governance and Scrutiny Officer, and with Charlie we look after all of the scrutiny panels.
Thank you. Hi everyone, so it's Gary Warbridge. I'm the Council's Strategic Director for Adults, Health and Communities. I'm here to support the panel.
Thank you all. Have we got anybody online? No. No, okay. We're just going to, I'm just going to carry on then. So item 1 on the agenda is apologies. I see that we have got one apology today. We've got Councillor Carol Ney subbing for Councillor Nicola Cook. So no others, have we? We haven't had anything at the roll here, haven't we? Yeah. Item 2, declarations of interest. Do members... Ray?
Good afternoon, Chair. I sometimes work at Derriford Hospital for NHS professionals.
Well,
I'm an employee of University Hospitals NHS Trust.
Okay. I'd just like to declare on item, whatever item it is today, item 11, drug and alcohol. I'm a trustee, and I sit on Hamos as a trustee. It's non-paid, so it's just a personal. I just need to declare it is in my register of interest. So, thank you. I'm going to go to item 3, Chair's urgent business. There is none, so I'm just going to go to item 4, minutes of the last meeting. I just need somebody to confirm that the minutes are held on the 11th of March. Can I just propose and get a seconder that they were correct? Carol, I've got Carol and Keith. Carol is a proposer and Keith is a seconder. Thank you. And then we're going to go to item 5, Directorate Business Plans, and that's you, Gary. Thank you.
Thank you very much, Chair. I think this is just a kind of early heads up and sharing of information for the scrutiny panel today around business plans, and then hopefully we'll bring them forward for people. What the council has wanted to do, and all directorates have something called a business plan, and what we're trying to do is make sure that the contents of those are shared through scrutiny. And the reason for that is each directorate's business plan tries to achieve a number of different things. Firstly, it will set out some of the things that it is doing to make itself more effective, more efficient in terms of its operation, and for us, some of the services that we provide. But what it also does is it also sets out some of the areas where we're going to work to try and to improve outcomes for people in this city, as well as help make sure that all the work we do helps ensure the council remains financially sustainable. So in each of the directorate plans, there will be a number of themes and areas of work that we're working on. It's felt really beneficial to now bring those to scrutiny, to share the contents of those. One, because it gives you a really good idea of what we're doing as a directorate in terms of all of our plans. It also gives you information around areas of interest you may have in terms of wanting to bring things into more detailed scrutiny. And I think, Chair, what we're hoping to do, once we've taken Maria, who's our first scrutiny today, through all of those plans, is to bring that to the next scrutiny session, and then have a session on taking everybody through all of that content to give people a bit of an overview from the directorate perspective. And I think that's really, from what we wanted to say today, we just wanted to land and introduce that idea for people today.
Yeah, that's absolutely fine. Has anybody else got any questions for Gary on that? No. Okay, that's just for noting then. Thank you. No, there's a change of order of business. Unfortunately, there is another meeting going on, so the next item can't be until later in the agenda now. So I propose that we bring items 7, 9 and 8 to enable Councillor Taylor to be in attendance for a relevant item, Life Centre Climate War petition and HESA finance report. So I need a proposer and a seconder. Yeah, and proposed will second. Thank you very much. So we're going to go to item 7 now, which is the Integrated Care Board Plans, Governance and Finance. And have we got? They're not online, or?
Through you, Chair, I'm just trying to track down Chris, who obviously is presenting this item. I would probably suggest, whilst we're waiting for a response, we move to item 9, performance, and hopefully by then I'll find Chris.
Okay, we'll go to item 9 then, quarterly performance report for adult social care. And we've got Julia, Service Director for Adult Social Care, to present the report with Councillor Maria Lawson.
So this report provides members with an overview of adult social care performance for May 2026, covering demand, waiting times, service activity and key improvement programmes. Overall, the report highlights a mixed picture with sustained high demand and ongoing pressures with assessments, reviews and occupational therapy services, alongside positive progress in areas such as direct payments, reablement, transformation and continued work to reducing waiting lists. The report also outlines the actions being taken through our Stronger by Design programme and partnership working with Live Well South West to improve timeliness, productivity and outcomes for Plymouth residents.
Thank you. I don't know whether we're able to share on the screen or whether people have got the information in front of them. Is that all right? Yeah. Okay, thank you. So the first item on our performance report, I suppose the first thing to say is, for those that have been on the panel on the committee before, there is a bit of a change to the data, a bit of a change to the narrative and how it looks. We are looking to try and update some of the language and the terminology. And also we're trying to have a think about what else might be helpful for you to see, what else might you want to to see on this report. So we are aware that there's some things on here that we would like to bring another time. And I think our business plan will help to highlight some of the things that we're working on that we want to bring. But the first the first lot of performance data is around our waiting list for new Care Act assessments. This remains high. We are once Care Act assessments have been allocated, individuals have been allocated to workers, the assessments are taking slightly longer than the 20 days that we have put in as a target. Again, a mixed picture as to why. The complexity of some individuals, the assessment process can take quite a period of time. It's not just a one-off visit for individuals. We're doing in order to counteract some of that, we've launched a proof of concept, which is looking at more of a prevention approach to people, and we've taken a number of people off of the waiting list to see whether or not we can offer them something less statutory formal, I suppose, than a Care Act assessment. Is there anything we can do to help signpost them, to help support them to be more independent, make better use of the voluntary sector prior to needing statutory services? We're about to bring some information back for that at a later date, but we have taken 42 people off the list that you're looking at now. Obviously, we're in July now, so the information you've got is a little bit behind the curve. The main thing to say in all of the performance around this waiting list activity is that the productivity is key. We are working really hard with our partners in Live Well South West to understand the caseloads each of the social workers has, their level of efficiency, how productive they are, and how quickly we can help them start to move people through the pathway, I suppose, if you like, from being allocated to a worker. How can we support people to move more quickly so that they're ready to take on the next case, the next individual? We want to make sure that we are being able to offer a timely response to all our residents, and not just those perhaps who have been on the list and are coming to the top. Obviously, we base all of this around levels of risk as well. So, shall I just move on unless people have got questions? Is that okay? Oh, yeah.
John, can we just let Julia go through the report and then we just ask questions after? It just makes it easier. Cheers. Thank you.
Thanks, Pauline. So the next lot of information is around our review activities. So this is about how many people are reviewed. We have a statutory responsibility to review people within 12 months, and this really is looking at our performance in this area. Our review activity is low, and we are hoping this will be increasing from August, September due to some of the changes we've made to our reporting. This is to make sure that all review activity is being captured and not just the reviews that we have been doing to date. So where we've only completed a sort of a more focused review piece of work with people, that's not necessarily always been captured on our reporting system. So I think the information doesn't do justice to all the good work that's taking place. So we are hoping sort of by August, September, we will start to see that change. Alongside, we are still focusing our reviews to manage risk and maintain people's independence for as long as possible. So next slide, please. Occupational therapy, huge amount of work has been taking place with our Live Well to review our performance, which will be reflected in the next report. We've had a reduction in numbers of people waiting since we started looking at this, which is off of this report. We're from 895 people down to 655 by May. So we are bringing the numbers down, which I'm really delighted about, and people have worked really hard to do so. We recognise people are still waiting too long. And again, the key to this is looking at our productivity and caseload management. Live Well have brought in an expert therapist who is working with the team to look at their productivity, look at their waiting list management, and look at how they are allocating work to their staff alongside have we got the numbers of therapists right, and are they in the right place to help people receive the support they need at the right time. Let's go to the next slide, please. We'll bring in Lou.
Yeah. Thank you. So just a short overview on residential and nursing care placements. We do continue to see that sustained demand for both residential and nursing care. the vast majority of our placements in residential are for older age adults, aged 65 plus. However, we are starting to see a slight stabilisation in those numbers. So the demand is still there, but it hasn't increased dramatically over the last couple of months. In terms of our nursing demand, what we're really seeing now is complexity of care in terms of those placements. So a much bigger request for placements around dementia and dementia nursing. So that is something that we're looking at in terms of our market development and our market sufficiencies. How do we grow that market to support that growing complexity in demand? Obviously, with the demand comes the cost and the budgetary pressures. What we do see is a number of placements being made above our budgeted rates, but we are working with our market to address that, but also to understand a little bit more about our care home fees and whether we are in line with our neighbouring authorities. Is it me again? Yeah. Oh, it's me again. Sorry, me again. Home care. Big push, big numbers in our home care space. But it's really important to look at the average hours rather than the number of people, so we know how many packages of care that we do have. Those average hours have been going up slightly. We have got a piece of work which is about to commence within this financial year around the re-procurement in our home care market. So we will look at how we deliver this differently within geographical areas, enhance the level of care at home that we can provide. So we're maximising people's independence, building in that prevention, keeping them in their own homes through the use of enhanced care, digital and technology, and also just growing and understanding more around what we need to commission and procure for the future to meet that need.
Thanks. Next slide, please. So looking at our reablement offer, we obviously work with our NHS partners to ensure people are getting the right support at the right time, as the majority of these are individuals who are leaving hospital. We have had a slight reduction in the number of people who have remained at home 91 days after discharge, but that is starting to pick up again. So we were hoping to be back on target, which we have been on for quite some time. This work is really, you will start to see this coming through in our business plan in terms of our Stronger by Design transformation programme. So working with teams of people, ensuring that we get a really proportionate response to individuals, that we're not putting in long-term packages of care for people the minute they leave hospital, when making a bit more of a lifelong decision is not the right time for them. Really important that we are supporting people to be as independent as they can, and really using their own strengths and assets that they've got available to them. Go on to the next slide, please. So direct payments continues to grow, which we are delighted about. This really ensures that people have got choice and control over how they spend their personal budgets. And I think really important and key for me is the growth for people who are under 65, so that working age adults are able to take some more control over their lives. And the final slide was, we're really pleased to see that we're starting to get a report on both complaints received by Plymouth City Council and Live Well South West in relation to adult social care. So we're starting to look at themes with Live Well, and the themes are, probably no surprise, are around communication to individuals, frustration over waiting times, which we completely recognise, and managing people's expectations about what we can deliver and what we're required to deliver, what we can deliver and what is available to them. And that's it. Thank you.
Thank you very much. I'll go first, and then Paula take down councillors that want to ask questions. So, how does Plymouth's performance compare with similar local authorities? So, I'm assuming we're benchmarking against other local authorities. How are we comparing against them?
So there are a number of different ways that we can compare ourselves. So some are our comparator size authorities, so made up of the same similar demographics, similar urban or rural kind of composite for the cities, and some are obviously our neighbours. So it's probably we could bring something where we've got some data that tells us much more of a comparison on individual areas. So there might be something around safeguarding, there might be something around waiting list. It won't be numbers, it'll be percentages, I suppose, of people and the length of time people have been waiting. Very happy to bring that next time. Would be quite some detail. Different areas we perform well, different areas, some areas we perform less well. So one area we're not performing as well is of working age adults. We provide too much for working age adults and it costs too much compared to our comparators, which is why it's an area that we are picking up in some of our transformation work that we want to really dig into to see what we could do differently, what different offer we could provide. So that's just kind of one example of how we compare.
John?
Yes, thank you, Chair. I was just going to raise that under waiting list for new Care Act assessments, I think you said the target was 20 days. Well, actually, it seems to be about 160 days or more before people are getting assessed. Why is there such a big difference between the target and what's actually being delivered?
Yeah, so my apologies. It's 20 days for completion of the Care Act assessment. So once it's been allocated, we would expect that piece of work, so the full assessment piece of work, to have been completed within 20 days. These numbers are the numbers of people who are and how long they're actually waiting before they're even allocated to a worker, which we recognise is high. We did some quite significant work ahead of CQC last year, where we managed to reduce the waiting list quite considerably. And I think this is where we now need to start digging into why it's gone up. Is that because we've got more numbers coming through, or is that around the productivity and efficiency of some of the processes and the assessments that the staff are completing? Does that answer the question?
Well, I'm not quite sure, because it says average number of days to complete an assessment, 160, 150. How does that fit in with your 20-day target?
Go back to this slide. Can I come back to you on that? Let me have a look and just have a look into the information in a second. I'm not quite sure why you're reading that.
Can I ask members if you want to chat? You can go outside and chit chat, but we're trying to listen to the officers and show them that bit of respect. Thank you. So, John, are you happy with your answer, or are we going to come back to that?
I think we need to come back to it. I'm a bit confused actually as to what the figures are for waiting times and then how long it takes to be done and how many people. The figures look quite large.
Well, I'm sure the team will come back. Okay.
Sorry, I found the bit you were talking about now. So that whilst it's 20 days from allocation to completion of that assessment, the 120 days includes the time the person's been waiting. So that's why those numbers are different. We are testing out some new formula in terms of, and you'll see that across all of the different scrutiny reports. They're starting to look slightly different, and we've got a new format and a new suite of information. So if there is any feedback on it, and I can see that could probably be a bit confusing, we're happy to pick that up.
I think Gary wants to explain a little bit for you.
I just want to build on what Julia's talking about. When you come in through adult social care, there's a conversation with you, and then what you're doing, you're part of the team that's most appropriate to carry out your assessment. And then what can happen is at that point, you are also at that point, kind of, people try to understand the urgency or need, so they try to make sure they prioritise, as you'd hope, that you see those people who need us most first, and the people who can wait a while. So there's a few different sets of numbers. So once you've come through our doors and you're part of the team that's most appropriate for you, you will wait for a while for your assessment. And during that time, you should be contacted at points, and we should check that you're okay. Then, and the wait is the 160 days, which actually has come down through some of the waiting list time, but will bounce around. Then you've got the point from where a team allocates it to a staff member to go and do an actual assessment. We expect an assessment to take about 20 days. So there's an app, because sometimes there are a number of people you'll need to see and talk to, engage with. So there's a kind of average amount of time we would expect, and we would monitor that performance of a worker in terms of are they doing assessments in the time that we would think. Some might take longer than 20 days, some will be a lot sooner. So there's two different stats really being talked about. One is how long you wait until we start to do your assessment, and then there's how long it takes to do your assessment. I think that's the work. Is that okay?
Thank you.
Alison?
Yeah, I feel I want, first of all, I want to comment on that, because I think 20 days is a long time. I mean, are you looking at, this wasn't going to be my question actually, but are you looking at shortening that target period, even for somebody with complex needs? That's almost like a reason to get on with it, you know, to actually get that care in sharpish, not for it to take longer. I do realise there's a lot of work to be done. There's a lot of people to talk to, other professionals and family, you know, I know sorting out care and all the rest of it. There's a lot to do. But I think if that's taken longer than 20 days, then I suppose that, you know, the questions around, you know, are workers carrying too big a caseloads? Are they not able to actually focus properly on these cases to be able to actually get it, you know, get them sorted out? Okay.
Yeah, no, it's absolutely fair enough. I think some of the, this is an average. So some of the, like you said, some will be longer. Some of these cases may be people who are going through a court process. So it could take several weeks. So if you have a number of those individuals, and there will be some who are resolved within one visit, one assessment takes place and care is put in and they've got what they need. And others will take a significantly longer time because of the complexities around their care needs. So making it an average, I mean, maybe it might be helpful if we can bring some kind of taking out the outliers, or actually describing that a little bit more, in a bit more detail, because 20 days, if you're waiting for something straightforward, 20 days is too long. Whereas actually, like I said, if it's a court process or something that could, court protection, that could take several weeks.
So my question is about intermediate placements. Are any of these placements due to the lack of availability of domiciliary care packages? I can see that it's in your report, it says about kind of, you know, a period of time to recover, regain confidence. I just wonder whether any of these placements are for other reasons.
No, the intermediate placements refers to anyone who is in a short-term either placement in a care home or having short-term domiciliary care, home care, reablement support following hospital discharge. So it's totally appropriate that they're receiving that on an intermediate basis, not because we haven't got capacity in the marketplace.
Lauren?
Thank you, Chair, and thank you, Julia. I'm going to take us back to Care Act assessments for a little bit. I kind of want to summarise a little bit about what's been discussed already. I really echo Pauline's calls for some benchmarking, so we understand the kind of scale of the issue that we're dealing with locally and how we are comparing against other authorities. I also kind of echo Councillor Mahoney's comments around the difference between allocated wait time and unallocated wait time. And I do think there's a little bit of confusion in the room that I think might benefit from a bit of a deep dive at a future session on Care Act assessments and Care Act reviews, just so that we're really clear as a panel as to what the waiting process looks like and what the allocation process looks like. I do also wonder, what comes across to me when we've spoken about Care Act assessments in the past is that we have issues with capacity and resourcing, particularly in the ability for our care workers to be able to carry out these assessments. Is that the right understanding? And then kind of building on that, how are we speaking to staff carrying out these assessments around what improvements they think that they can identify within the service to make it run smoother?
So absolutely, I think a deep dive, and I realise some of our processes and language is deep inside the workings of how we manage the caseloads, and it probably needs to be a bit clearer so it's a bit more transparent and easy to understand. I think the looking at that kind of waiting time and the allocation process, absolutely, it does require team managers to spend time in supervision with staff, helping staff move people on from their caseloads and helping them close cases to give them capacity to take on more. Some of this work that we are looking at is our principal social worker completes several audits each month with looking at not just quality of the work that's been completed, but also numbers and the productivity of the staff. So I think that that for me is really key for us to understand, have we got the right workforce with the right skills in the right teams and in the right place? And until we start to dig a little bit more deeply into that with Live Well, that is going to be more tricky to understand. But work that we are completing that piece of work, and it comes through our workforce and practice improvement board, which would be perhaps helpful to bring something back here a future date.
Anne?
Thank you, Chair. Excuse me. I'd like to talk about the OT side of things, if you don't mind. Excuse me. I'm concerned with when I look at the unallocated waiting list, the longest waiter, the mean wait. You know, it's. I remember subbing on here about 16, 17 months ago, and from what I can recall from what was presented to us back then, this isn't an awful lot different. Things have improved. I know people have got massive caseloads and there is more demand on services, but we don't seem to be in an overly much more positive position than what we have been for the last X number of months. Are you able to tell me, as of like the end of June, how many people are unallocated on the waiting list for an OT? Because I know the report only goes up to the end of April, so it doesn't really give us kind of like a clear day of nearly where we are at the moment. I also wanted to ask about if, I know the way that the OT system works is you'll get flagged as different priorities. How long are people who are flagged as a red priority waiting for their assessment? And where it says at the moment that the waiting days, in the narrative it says about the waiting days remain high at 216 days, that's like 7 months. For what could be either a full-blown assessment of everything to keep somebody in their own home, or it could be for a single piece of equipment. But that single piece of equipment can be just as important as the whole home in order to keep someone in their home and stop them having to go into care. So just sort of like your feedback and your thoughts on that, please. And what can we do to try and improve these waiting lists?
Thank you. There's lots in there. Yes. Probably would warrant a whole section, perhaps at some point around OT and what is happening around occupational therapy. What I would say is this information still contains both health and social care waiting lists. So this hasn't yet showing that it's been separated out. The team have worked really hard to separate the two out so we can be really transparent that some of these people are waiting for a health occupational therapist assessment, not social care.
Sorry, can you elaborate a little bit on that? Because being new coming back on here,
sure.
Health assessment, social care assessment.
Sure. It sits very differently. So obviously a health assessment does not sit under the Care Act, whereas a social care assessment would sit under the statutory responsibility that we have as a local authority under the Care Act. So, but in this information, because of how the occupational therapy teams have been set up through Live Well, they are, this waiting list is combined. So incredibly helpful that you can see how many people are waiting and how long they're waiting for, and occupational therapists for the whole of the city. But if we are looking at scrutinising our local authority waiting list, this is overinflated picture that you're seeing. I will need to look into where we are currently in June, because I haven't got that information with me. But what I would say is, in terms of risk profile, the teams do prioritise those who are most urgent need, and I think the demand is outstripping the ability to see people. So they continue to see the urgent people, which is why the waiting list remains as it is and people continue to wait. I'm not saying that's good enough, and we absolutely are doing some work to try and resolve that. I have to say it's been a complex piece of work to try and separate out who's waiting for what and what they are doing with the teams in Live Well. So I'm really optimistic that next time we will have the change in information. So you should see a dramatic drop in the numbers of people who are waiting. But we can certainly bring a bit more information back about the risk profile of who's waiting for and most in need.
I think it would be helpful for some of the data if we did actually look at some case studies, and then we can plot the journey for the resident. I think that would be helpful, and then I think the facts and the figures become more real when we look at the problem.
Yeah, I'm quite happy. I mean, it's your call. I mean,
as a new person sitting on this scrutiny panel again, I would welcome as much breakdown of information as possible, because if our aim here is to be scrutinising what comes before us, as far as I'm concerned, the more information the better, because it's sometimes to understand what's presented in front, we need to know what's going on behind. And for me personally, I would please say, I didn't realise that the assessments are split down between health and social care. So giving us some examples, like case study examples of this is what comes under health, this is what comes under social care, that would be really, really useful. Thank you, Chair.
just following on from Anne, so obviously these waiting lists, is that a lot to do with staff too? Because is that affecting our performance also? Because have we got enough staff? It's those sort of things that's going to affect the performance of what we deliver. So if we haven't got enough staff to do this, to do the OT assessments or whatever they need to do, then that level is never going to go down. It's going to stay, or it's just going to increase.
Absolutely, and I think that's where we are working with Live Well to look at the productivity of the staff and the efficiency of the processes that they're requiring to undertake with individuals. If we can be assured that staff are enabled and are being as productive as they can, we can map that against the number of people coming in new onto the waiting list. And I worry that whilst we probably have got enough staff to deliver what we need to deliver, actually the people who've been waiting so long, unless we do something very differently for those individuals, there's sort of a bulge of people who we're not getting to in a timely way. And whilst we are continually looking and reviewing their risk level, what they're waiting for, and whether or not they have moved up the list in terms of risk and need, I do worry that whether we will get to the bottom of the list in a timely way. So we're really asking Live Well to get in and look at that list and really understand, are there alternatives for those individuals, and are they, are people really still waiting that length of time? And if they are waiting, what can we do to support them to wait well and get some support where they need to?
Ray?
Thank you, Chair. Patient, customer, resident feedback. How do we use that information to sharpen services, the way we provide things for them?
Yeah, no, absolutely. Live Well provide I want great care feedback, and I think from previous scrutinies, our principal social worker has presented some of the feedback that we've had from individuals, and whether or not that's something on a kind of 6 monthly basis or in a year or however frequently you want, we could bring here. But we do ask for feedback. We do ask for feedback from individuals, and I think there are a number of other forums, which I don't know if you wanted to mention the other ways that we gather feedback.
Thank you. So from a commissioning perspective, we have a co-production toolkit, which involves a lot of engagement with, various customers, partners, voluntary community sector around the experience that they have of our services and how we shape those services moving forward. We hold regular forums with our care homes, with our home care providers to give them an opportunity to feedback and feed in. We obviously take our own complaint information as well that from complaints that we receive about our services and use that as learning. And I think finally there are other forums that we have in our community sector, such as our Dementia Alliance partnership, where we work really closely with our voluntary sector partners to really understand need and have that person feedback and have it feature really strongly in how we shape and how we shape those services.
Okay, I'm a bit conscious of time, so I've got 2 people left, so I'm not going to let anybody else ask any more questions on this, but we can always bring this back for further scrutiny anyway. So I've got Carol and then I've got Keith.
Thank you, Chair. It's nice to see you back in the chair as well. Welcome back. All right. I was just going to mention really about the Adult Social Care New Care Act, page 44, assessments. Yeah, I think over the last year we've constantly seen these red arcs that we're not making targets and we're not doing things on target. And I just wonder, if you look at last year, June 25 to this year, average number of days, I mean, it has gone down, but we're not making any waves here, And we can sit on these committees every time and say, yeah, that's bad. Is it staff? Yeah, that's bad. Is it number of people coming into the city? That's bad. Is it the weather? But actually, we need an action plan. We really need an action plan. Otherwise, next year, Pauline, maybe, and whoever is sat here, and we're going to be saying exactly the same things. I remember speaking about this in February and March and saying, we're not meeting targets, we're not doing this, is it this, is it this? It's time for an action plan. That's what we need to do. Otherwise, we'll be sat here with grey hair, false teeth, saying, we're not making targets, That's my opinion. Thank you.
Keith?
Thank you, Chair. Mine's just a general question about re-enablement. I struggle to get my teeth around that one sometimes. Re-ablement. How successful are our re-ablement packages, services in helping people regain independence and avoid long-term care packages?
That's a really good question. And I think we have had some really positive outcomes for individuals. We've got a number of case stories, which we're very happy to share with everybody here, where we have supported individuals who perhaps came to us wanting a level of care or expecting and feeling like they needed a certain level of care. We've supported them to perhaps find things in a different way. So one particular individual supporting them to access the community, access the city through the use of a different type of wheelchair. They were able to be more independent. They weren't then stuck at home waiting for a carer to come and take them out. So I think some really great success stories, which has also cost us less, but also has been a really positive outcome for individuals. So it's measured against, it's slightly measured against cost, but also really importantly measured against outcomes for people.
Julia, I know Alison wanted to ask a question, but we really do need to move on. Alison, you're more than welcome to send Julia an email and ask her a question. Sorry?
For a particular data before which was agreed to, and I've probably asked 2-3 times and it hasn't been provided, so it was just a really quick reminder, but I'll speak to you after.
Okay.
Yeah, sorry.
No,
really
no,
sorry,
that's
Chair.
absolutely fine. I obviously the recommendation is to note this report, but I think also we need a recommendation that we just need to bring OT in and do a deep dive on OT assessments and everything that goes with it. And so if we can have that as a recommendation, Elliot, because I think this is, members are absolutely right. We don't really see a drop in the figures. So it would be a case of bringing in Live Well as well to explain to us what's going on, because yeah, we see this, you're right, we see the same figures every year. We don't really see an improvement. So if we put that as a recommendation, that we just actually bring that back. Okay, thank you very much. And now I'm assuming now we're going to go back to ICB, and I've got Chris and Ben Chilcott. Yeah, that's who we got on. Yeah.
Yeah.
Yeah, well.
Thanks, Chair.
Welcome.
Bad news that we weren't here earlier. Had some connection issues earlier. And sorry, I can't be with you there in person today. I'm Chris Morley. I'm the Place Director for Plymouth in the ICB. There's two papers that we provided as part of our report update today. So one gives a few general updates from an ICB perspective that I'll just give you a high level of, and then I'll hand over to Ben to introduce himself and then take you through some finance updates that have been asked for too. So just covering the first paper initially, there's some detail in there in terms of the clustering arrangement and the reorganisation within the ICB. So since actually we last presented and updated, Mark Hackett has been appointed as interim chief exec in the ICB and is now in place. Mark knows the city well, having previously been an interim chief exec for a number of years at University Hospitals Plymouth too. We're continuing our process in terms of the reorganisation. The ICB now have execs, the majority of directors appointed, and we're now moving through the process in terms of appointing broader staff teams that will support the work we need to take forwards. The background to this is set out in the paper, but is about the change in role of the ICB as we move to more strategic commissioners, and also looking at how we reduce running costs in order to move more money to the front line ultimately. We are now in a cluster arrangement. It's important to recognise that place and our place working arrangements absolutely sit front and centre in terms of the operating model, and that commitment to Plymouth continuing in that way is one that continues really. The other updates within the paper, so there is some detail in there around the NHS Excellence Awards. So it's really helpful to bring that here because we're really delighted to share that the teams and individuals in Devon and Cornwall have been named as regional champions. And actually there's 3 areas that were successful within Plymouth specifically. One around delivering value and redesigning pathways to eliminate need for IV beta blockers. Another one which I know we've had a number of conversations over the years through overview and scrutiny around end-of-life support. And actually University Hospitals Plymouth were successfully champions regionally in terms of some of that system-wide which I know has been overseen and through this group too. But absolutely supporting patients to be comfortable heard and where possible to be in the place that they want to be. So it's helpful to kind of bring that update and share that positive impact of that that's been recognised through those awards. And there's Plymouth again through University Hospitals Plymouth around quality improvement and recognising work that's been done to admit patients directly to acute medicine, so safely bypassing the emergency department where that's appropriate. So some good news stories there. And the final thing that I just wanted to share again, another positive thing for the city, is the official opening of the Community Diagnostic Centre. I'm sure most people will be aware of now, is now fully open in the West End. It's a £22 million facility with a wide range of scans, checks, tests, and that's being centred in a convenient community-based setting, expected to support over 91,000 tests each year. Really will support individuals to access the tests and diagnostics that they need in a community setting closer to them, easing pressure on Derriford, and also having a positive impact in terms of driving footfall into that end of the city. As described in the paper, those appointments are by referral only, but it's been very much a real positive forward step in terms of delivering that faster, more accessible diagnostic for the local population of Plymouth. So I'll let then pick up the finance update, and then we can come back to any questions people have got.
Hi, so Ben Chilcott, I'm Director of Finance in brackets Strategy and Planning, one of the Directors of Finance for the ICB, for Devon ICB, I should say. So you've got a report in the pack, and I'll just contextualise that in a minute. But NHS Devon, I'm sure you're all aware, is the Strategic Health Commissioner for Devon. As Chris said, we're currently in a cluster with Cornwall, and we're restructuring our organisation administratively to work across both patches, and with a plan to merge probably from April 27, at which point our budget will be about 5.5 billion. In the paper that you've got there, you've got an outturn for 25-26, which for the Devon system, so that's the Devon ICB plus all of the NHS providers within the patch, an overall deficit of 64.3 million. Within that position, there was a huge amount of non-recurrent funding within that position, or non-recurrent savings, which means that the underlying position, as it says in the paper there, was 286 million. So that was the start point for our 26-27 plans. The paper says we're still underway reaching a final agreement. We have now reached final agreement with NHS England. We do have a balanced plan, so a plan that delivers break even for the ICB and for each of the NHS organisations within that within the Devon footprint. But that does come with a significant level of risk. Within that planned break-even position, we have got a material amount of non-recurrent funding as well, deficit support, but it's also reliant on 300 million of efficiency savings. So as set out in the paper there, the things that we've been focused on to this point are about de-risking our plan, and that's making sure that the delivery of that 300 million of efficiencies is as robust as possible. So we're focused on that materially at the moment, and then in addition to that, we've put in place some architecture for assurance of delivery across the system, and those things are set out in the paper. So contract review meetings, so we contract with each NHS organisation for a level of activity and delivery of performance targets around referral to treatment, cancer weights, etc., and overall waiting lists. And the contract review meetings are something that we didn't have in place previously, because we managed block contracts with each of our providers before, whereas this year we've moved to a variable contract, so we are paying for activity as it delivered. More activity is done, the more we will pay for, and that brings with it its own set of risks. Financial oversight group, so the blueprint for ICBs, and the reason why we're restructuring is because the responsibility for ICBs, or rather the share of responsibilities between ICBs and NHS England has shifted recently, and the responsibility for financial performance management of providers sits with NHS England, but because of the level of risk in our system, we need to do that jointly. So we've set up a set of processes where jointly the ICB and NHS England oversee the finances of the providers. And then the third thing there is about investment panels. So given the level of risk in the system, we've introduced a process called the triple lock. It's been in place for some time in Devon because of our financial challenges, but we've made it more robust this year, and any investment over 50k has to go through this triple lock process, and that means it gets triple lock approval from the ICB, NHS England and the provider. So it has to get through 3 boards. So that's where we are at the moment. Our you haven't got a year-to-date performance there, so we don't report as an ICB. We don't report at month 1. Month 2 report hasn't been to our board yet. It's going to the next board, but without breaking any confidences, it does say we are delivering break even at this point, or at month 2. And you've got a brief update there for University Hospitals Plymouth Trust. So we're not responsible for them. They are their own organisation, but we do contract with them. But because it has a significant impact into Plymouth, you've got the update there. What I can tell you is that they have now agreed a break-even plan, but they do have a material 8% efficiency target in order to deliver that. And we're currently working with them and monitoring that and ensuring that they become more and more robust in their delivery of those efficiencies. They are currently reporting on plan at month 2 as well. So I'll pause there and, along with Chris, answer any questions.
Thanks, Chris. Thanks, Ben. We did lose you in the middle there, Chris. We couldn't hear what you were saying, but that's absolutely fine. I'm sure members will probably have questions that they want to ask you anyway. So I've got Ray.
Thank you very much, Chair. Good afternoon. Savings and efficiency savings, and quality of service. How's quality of service going to be affected, and what kind of efficiency savings are you thinking of making?
So in terms of quality, glibly, I could say that quality comes, that higher quality is cheaper cost. The reality is we absolutely focus on quality, and a lot of the efficiencies are about productivity and making sure that we don't lose the quality aspects when we're focusing in on financial savings. And that's why we have a multitude of targets. So it's not just financial balance, it's performance targets as well. So delivering referral to treatment targets, delivering on cancer weights, and all of the NHS constitutional targets. So we focus on both of those 2 things. Generally, the efficiencies are made across lots and lots of different things. If I give you an example on the ICB efficiencies, when I say we're restructuring at the moment, we're right in the middle of that process. That's saving for us £12 million. And that's about significantly reducing the amount of bureaucracy, the numbers of people in post, and refocusing what the purpose of the ICB is. So it's very much a case of doing things differently, and it will be productivity. So for acute hospitals, it'll be a vast range of things, but it will be mainly focused on productivity.
Anne?
Thank you, Chair. I have a few, besides what I actually wanted to ask you, I have a question. I'm slightly confused. Productivity, quality, savings. I don't see those 3 things going hand in hand. Making savings will normally impact on a service. It ultimately impacts on staff and staffing structures and staffing levels. So I'm a little bit concerned that with your response to that, but sorry, that's more of a statement from me, sorry. What areas though of performance are currently causing the greatest concern for the ICB, particularly in Plymouth, and what plans are going to be put in place to address these?
So do you want me to pick that up? So in terms of Plymouth, I think there's two things. One is elective demand. So understanding what is what's the demand pitching up at the hospital, how much capacity they've got to deal with that demand, and how we can manage that demand such that it is such that it can be dealt with within the overall resources, the activity that we've contracted from the trust. So elective demand, and we've got lots of work underway at the moment in terms of the county-wide demand management schemes. So lots of work going into that, and we could go into that in a bit more depth in another session probably. And the other is around non-elective demand. So urgent care services going through the hospital, going through A&E and admissions, and those. And then the third area is obviously the discharge and no criteria to reside. So the levels of patients who are fit to leave but are unable to because there is no onward placement for them. So those are probably the three key areas in Plymouth. They're actually consistent across Devon, so across Exeter and Torbay as well. But those would be the areas that we would focus on.
Worth acknowledging Ben since it from an urgent emergency care perspective and discharge perspective. Many members will be familiar that actually we provided regular updates into Scrutiny previously, and actually significant improvement that Plymouth, the University Hospital Plymouth and for the city have made in that space. But always there continues to be a need to continue to drive that improvement work alongside the hospital team and Livewell and Plymouth City Council in terms of understanding our respective role in supporting that and addressing those challenges.
So I have a further question, if you don't mind following on from that. So with the various services that come under the ICB, one of them is the continuing healthcare funding. That's correct, yeah?
Yep.
Yep, thank you. With the mergers that you are talking about, what impact is there going to be on the continuing healthcare funding and how assessments are undertaken?
So it continues to be a statutory function that the ICB is responsible for, and there is a team of assessors, as I said earlier, we're working through at the minute in terms of the broader reorganisation process. So that's being considered, how we can take learning from across both areas in terms of delivery model, in terms of the development of that. I'm not the commissioner continuing healthcare. I think if there's a particular interest in that, we could always arrange for that to come back if that's something that the committee would find useful. We could ask for an update in terms of that specifically.
Thank you. Lauren?
Thank you, Chair. Brilliant to see the opening of the Community Diagnostic Centre. It's a beautiful space. I was really lucky to tour it a couple of weeks ago. My question is just around the level of capacity that is opening up for Plymouth. So over 90,000 diagnostic tests a year. How much of that is created capacity, so new capacity, versus capacity that has been deferred from Derriford?
So I can get the exact proportion for you. It is a mix. There is some services that have moved out from Derriford in order to support. There is additional capacity though as well, and capacity that we didn't previously have in the city run by the hospital in quite the same way. So it's a combination of the two, but I'm happy to kind of follow that up outside and come back to you with the exact split.
That'd be really helpful, thank you.
Will?
I suppose in line with strategies like the NHS 10-year plan, how effectively is the ICB working with partners like Plymouth City Council to shift the investment towards prevention and community-based services rather than relying on acute care?
Thank you, Councillor Noble. Yeah, really good question. And so certainly a real focus on that at the minute. So we have our One Devon plan, which is our 5-year commissioning strategy, in line with the NHS 10-year plan. Absolutely front and centre is how do we enable that shift to prevention and also move traditional hospital activity out into the community and develop integrated neighbourhood teams. So within Plymouth, we're driving that work through the local care partnership arrangement that we have, which reports directly into the Health and Wellbeing Board. And we've been working really closely alongside Steve Madden as DPH is supporting in terms of chairing that LCP group now, alongside commissioning teams and those broader partners, both health and social care partners, but also really strong presence of the voluntary and community sector within those groups too. So we're at the point at the minute that we're setting out what our plan for delivery of that is for this year, with a real focus that we make sure that that's all encompassing of all partners in order to enable those shifts that need to take place.
Got another question, Will?
Yeah. Oh, so how will your financial recovery plans protect the frontline services for Plymouth residents? And what safeguards are in place to ensure that patient care is not compromised?
Ben, I don't know if you're best placed to describe that in terms of the...
Yeah, so I think to an extent it's back to the same answer that I gave before, is that we've commissioned a level of activity which is sufficient to deal with the healthcare demand for Plymouth, both electively and non-electively, and within that we're working with UHP to ensure that their efficiencies and the efficiency program that they need to put in place in order to live within that resource works as best as possible and doesn't impact on performance. So the performance requirements that we expect of them, which is referral to treatment, cancer weights, and so on.
Is there any more questions? No. Thanks, Chris. Thanks, Ben. See you again soon.
Thank you. Bye.
Thank you.
Bye. Now we're going to go to item 8, quarterly finance report for health and adult social care. We've got Councillor Maria Lawson and Helen from Head of Finance.
Hello.
Hiya.
So eagle-eyed, I'm actually will notice this isn't a quarter one update because we're not due to report our quarter one position just yet. So this is a month 2 update, and at month 2 we really do look high level at developing risks. So you'll be able to see it's a nil variance, but there are risks identified in here. The main risks are, as a demand-led budget, that demand is potentially rising more steeply than we had budgeted for. And alongside that, then that could potentially affect the delivery of savings targets. And another aspect that some of our savings targets are staffing related. So where resources may be required to support enhanced service delivery and transformation activity, that also could impact on our ability to make our savings targets. But a full breakdown will be done of all budgets in the Adult Social Care Directorate at quarter 1, and you'll be able to see that report. The Financial Recovery Board is now well developed and meeting regularly, so they will be picking up all these risks as part of their work. But what I did have included, just because we've got sort of new faces in the room, is a breakdown of the adult social care budget and how it looks. If you do have any questions or want to understand better any of the elements of the budget, please do just drop me an email and we can talk through that with you. But just to high level, the adult social care budget is the highest revenue budget in the council. Net budget is 133 million, but within that there's 173 million gross spend, and there's a table there that breaks down the different types of care package budgets and which are the highest. So you can see residential long stay is our highest budget, then supported living, and these kind of bring to life sort of what Lou and Julia have shown you in terms of performance and how that's related to the size of expenditure that we have. We that spend is netted off by a significant amount of contributions from clients and health, so that's about 40 million of funding that offsets those care packages, but it really is one of the biggest budgets, and alongside that carries risk of, you know, larger overspends. We've also given a breakdown of the savings targets as per the budget that were factored in for this directorate, and they're all currently on track to be achieved at this point. So happy to take any questions on PCC finance.
I've got Lauren and then I've got Anne.
Thank you, Chair, and thank you, Helen. I am picking up on the prevention point that is marked as an amber risk in the RAG. I'm assuming that that's because some of that additional capacity that we'd hope to free up in the budget is then being spent on rising demand. But I'm wondering if you can dive into that a little bit more and tell us what projects might be undeliverable with that kind of risk there.
Yeah, so I think the risk there is that is based on individual and their needs, but I'll probably pass over to Julia. Did you want to pick that up about the prevention?
Yeah, definitely. So the prevention budget is always really challenging to demonstrate how we've prevented people requiring care. So we are working with people to meet their needs earlier with alternatives rather than putting in a paid for statutory care package. In order to do that, we do need the staff to be able to deliver some of the reablement. So there is an offset, I suppose, in terms of what we might need in terms of funding in order to deliver that better solution for people that gives better outcomes. Longer term is more cost effective, but does present a challenge and really difficult to predict. Are we going to achieve that or are we not? We're making some good inroads in achieving some of that to date, but again, at month 2, we had achieved 70,000 in terms of savings, which is fantastic. So really great work for the teams and all the people that have worked so hard, but really difficult to predict, are we going to achieve that in that timely way by the year end?
Anne?
Thank you, Chair. Just following on from what Lauren has raised there, of course, going back to the delays with the waiting list with the occupational therapists, you know, prevention, that comes in under prevention, and I guess you're going to struggle perhaps to move out of the amber risk with prevention until we get on top of the OT waiting list. I think that's a safe assumption and a link in to make. What I actually wanted to ask about was the bad debt provision review and reduction. I remember previously from sitting on the scrutiny when I was subbing, there was some, Gary will correct me if I'm wrong, because he's got a good memory, there was some like £8 million or something still owing to Plymouth City Council in respect of fees and service fees that were clients' contributions. What position are we in on that at the moment, please?
I don't have the current level of debt. Do you have no? So we can get that for you. And you're right that then, because there is a high level of debt, that could affect our ability to make that reduction in our bad debt provision because that tracks alongside it. But we can get you the current level of debt.
Through you, Chair, sorry. I would have thought that when we have the breakdown of the adult social care budget here, that we perhaps also have some way of being able to show on that report what the current level of debt is that is owing to Plymouth City Council, if that would be acceptable.
Yeah, we can put that in quite simply, I think, yeah.
John?
Thank you, Chair. Can I just come in on that? Is a lot of the bad debt actually people whose care fees are being paid pending perhaps the sale of their property? So is it sort of debt that is likely to be repaid, or is it just people who are not paying, as people don't pay council tax, etc.? What is the split?
So I think there's probably a lot of different scenarios about why something would be classed as bad debt, but in the bad debt breakdown, it does have different categories. So if we bring you some more information, that might be able to answer some of your queries. So, okay.
Anybody else got any questions? No. Thank you, Helen. Really appreciate it. Thank you. Right, we're going to go on to item 10, community meals provision. And we've got Mark Collins. Oh.
I'm going to do the introduction, Paulie, Chair, if that's okay. Thank you. So thank you for the opportunity to present the report on the community meals service previously delivered by Catered. The purpose of today's report is to provide assurance on the decision to end the service, the support provided to residents during the transition, and the outcomes since the service ceased on the 28th of February. For many years, the community meals service played an important role in supporting some of Plymouth's most vulnerable residents. However, the service became increasingly financially unsustainable. While approximately 150 people used the service, rising operational costs meant that the adult social care subsidy had increased to 216,000 in 24-25, equivalent to £5.40 per meal, in addition to the price paid by clients. This resulted in an overall meal cost of between £13.65 and £15.35 per meal. At the same time, Catered was experiencing significant financial challenges and required additional support from the council to remain operational. Given these circumstances and recognising the wider financial pressures facing local government, a managed and planned closure was considered preferable to the risk of an unplanned service failure. An executive decision to cease the service was published in December 2025, with a clear transition period established to support residents. Comprehensive communications were issued to all service users, care providers and social workers, with information provided about alternative meal options and other support available, if required. The report therefore sets out the background to the decision, the actions taken to support affected residents, and the position today following the successful conclusion of the service. I and other officers are happy to take any members through the detail of the report and answer any questions.
Mark, did you want to say anything?
Thank you, and thanks for inviting me today as well. Just a bit more of the background that went into this. It wasn't an immediate decision. We did look into other options available first. We went out to the market to see if we could source an alternative provider who would take over delivery of the community meal service. We had two providers that initially expressed an interest and came forward, both of which withdrew when they realised the costs that were going to be involved and stated that they would not be able to make it financially viable without a heavy subsidy. So that's when that decision was reached, that we were unable to get another provider. So the solution, unfortunately, was to remove the subsidy from Catered, which meant that the meals couldn't be delivered. Whilst making that decision, we also took extensive research into what else was available. So we looked at all of the food deliveries, such as Wiltshire Farm Foods and several other providers who do the similar thing. We also had the Community Meals private company or charity that does it through Devonport Park. So we looked at them and also spoke to them about whether they could take it over, which they couldn't. So it was quite an extensive research process that went into what could be available, and unfortunately it did mean that we weren't able to carry on delivering the community meal service as it was. We wrote to every single person using the service to let them know exactly what was going on right from the very beginning. So as soon as the decision was published, they knew exactly what was happening, so they wouldn't hear about it through the press first. So they knew exactly what was going on. We offered a broad range of support available to them. So all of our social workers were aware of what was going on and aware of all the alternatives. All of those that were in receipt of social care packages of support, we informed those carers so that they were able to support those people and able to source an alternative provider, helping them make the orders and decide who they wanted and what they wanted. We also identified money through, at that time, which was the Household Support Fund. So in case anybody needed help with a microwave or refrigeration or freezers, if they didn't have that in place, so they could have proper food and stored properly, we didn't need to use that, but it was identified. We also then did some follow-up calls with several people just to make sure that they were getting the support and the help they needed. Throughout the whole process, I think we had only about 5 complaints, 2 of which were escalated to MPs, which were dealt with satisfactorily, and I think the people understood. And those that did complain, I think it was more about, not that they couldn't manage, but it was about that change, and there was a little bit of worry about who would come and visit them, because there were concerns that if they were having daily delivered meals, that they were getting somebody with an eye on them in that time. We were able to work around that because of the work that we have been doing with Elder Tree around our befriending projects and improving lives, and the work with the wellbeing hubs. So a lot of that support was able to be sourced and put in place for people, and they were given all of the support needs that we could find for them to be able to contact. So if there's any questions, I'll quite happily.
Thanks, Mark. Can I just ask, obviously all this support was put in at the beginning to make sure. Are we still checking that people are still managing, are they feeding themselves? I mean, you know, obviously if they had delivery of meals and whatever, that's all been taken away. So are we confident that all those people that were in receipt of that are eating properly?
I'm confident that anybody who was in receipt of adult social care is being supported properly, is eating properly, and that the care workers are checking and making sure of that. Outside of that, where people have their own capacity and are not in adult social care support services, I cannot hand on heart say I think they're eating properly. What I can say, the support mechanisms are in place for them to reach out and get the right support they need if they need it.
Brilliant, thank you, Mark. John?
Sorry to prolong this, Chair. Can I just come back on that? So the people who are not receiving adult social care support, I mean, they could even be getting the frozen meals being put in the freezer, but they may or may not be able or capable to actually then defrost them or heat them. So we don't really know that there aren't some people out there who've got no other private carers or whatever coming in who might just not be getting the food, or they might be getting it and not able to utilise it when they've got it. So we really don't know, and there are quite a number of people in that category, I presume. Is that worrying, and should something be done about it? I mean, there must be a list of people who you knew were getting the meals.
Everyone who was in receipt of community meal service, whether they were a social care client or not, was communicated with and given all the information that they could use. Where there were clients that we knew of through Caterhead who had difficulties, they had their next of kin details on file, or anybody that was acting on behalf, and those people were communicated with as well. So, for an example, there was the daughter of one lady that we're dealing with who was very concerned about her mum being able to manage her meals, so we were able to communicate with the daughter, to give her all the information that we had available, help her to identify the support mechanisms that were in place. So I am confident that everybody who was using community meal service were informed and knew what to do. And as you say, John, hand on heart, I cannot say that they've been getting the meals that they need, but without them coming forward for social care assessment, as we require now, you know, there's other support mechanisms that we require people to use to be able to get support, and these would fall in that same category.
Well,
hi, John. Just a quick question. The meals on wheels, it was called, wasn't it? That's what it sort of took the place of, was it, or was it part of that as a process as well? And I just wanted to know, when when did it start breaking down? What was the cause? What was the main cause? Was it cost of making the meals, the finance of staffing? When did you know that this sort of thing was breaking down? What was the main cause of this, and why couldn't that be fixed?
I picked this up in 2023, by which time there was already a heavy subsidy going into community meals. And I think when it was initially transferred across to community meals, or to CaterEd as it was then as a set-up company, it was quite heavily subsidised at the time, and the idea being that the subsidy should have reduced. It did, but then it escalated again very rapidly, and I think there are a number of drivers behind that. There's the changes to minimum wage, changes to employment legislation, there's the cost of living crisis, the crisis of food going up, which are all the same drivers that led to the financial problems that CaterEd are having with the school meal service. So I think one of the drivers for us, and then we knew at the close to the time when the decision was being made, that there was heavy subsidies going in to support the school meal service. It was either, do we have a sensible withdrawal of the service so that people can be managed, or do we do a crisis response, which is what it would have been in the end. Yes, maybe we could have put more money into CaterEd, but we didn't have more money to go in, and we did work with CaterEd quite a lot around, is it more marketing? Do they need a bigger client base to be able to make it viable? We tried to do some of that work with them. But at the end of the day, we're only now, or were, one in five, I think it's 18% of local authorities now only deliver community meals in England. So the number of local authorities that are delivering are having the same problem and dropping away quite dramatically.
When you realised that it was going downhill, did you do a risk assessment? Was there some sort of risk assessment done, financial assessment, all that sort of thing was in? And who did you contact? Who did you deal with? Was there a plan of attack on this sort of stuff, or did you?
Yeah, I mean, it wasn't done in isolation. It was done
No.
across the whole of adult social care department, working with our directors and service directors. We worked with finance as well. We worked very closely with Brad Pearce, who was the chief executive, who was running CaterEd. So there was a joint approach around, is there anything, what can we do, what can we try? So yes, I mean, every avenue was explored before it was the final decision had to be made that we could no longer afford to subsidise and keep the service running.
Smashing, thanks very much.
Thank you.
Karen?
Thank you, Chair. I just wanted to ask two questions. The first question is, CaterEd, is it a not-for-profit company or is it a profitable company? That's the first question. And then secondly, I'd like to say that I've looked through everything. I've followed this very closely because I've got one lady that really contacts me weekly about this because she's had to pay for a carer at lunchtime to work her microwave for her. And I'd like to just say that we've obviously made a decision, but we've saved the PCC canteen for CaterEd. We've saved the cafes. They've been saved. And I just wonder if it's a not-for-profit company, why are we not able to subsidise the meals? Because if we look on Companies House, CaterEd in 2024 has 360,000 in the bank. So obviously it was okay at that point. So if you look from there, you know, maybe we could have contacted residents, because 150 meals is not a great amount, like you've admitted, and said, could we pay a little bit more for your meal? Could you pay an extra £1 for your meal? Because I literally have a lady that messages me a lot because she's paying now an extra care fee every day to work her microwave. So I wonder whether it was more rational to maybe sell out the Central Park cafes and keep this, because this is a social care aspect. Thank you.
Right. First one is that CaterEd is a local authority company. It was jointly owned by the schools and Plymouth City Council. So it's a TECL company. The saving of the fully catered element, if you like, was a fully funded trading arm within that, which has been transferred to Plymouth City Council. I would know part of those decisions. I only know as much as you do around that. I was not part of those discussions on whether that was saved. That was dealt with through the schools and the local authority. So I can't answer that one. In regard to the cost of meals, I said 150 clients, not 150 meals. So that turned out to about 700 meals a week. the cost of the meals, we were already subsidising to extent of £5.50. The social care clients were already paying £8.95 or £8.25 to £9, depending on whether they're eligible for VAT or not, which did mean that they were the highest priced community meals in the country already. Of the few people that we did do some research with, talking to social care, they were not prepared to pay any more because of the amount that was being paid already, and felt that adult social care should pay for it. Food is a daily living cost, which we are not allowed to subsidise through the adult social care budget.
Gary, I understand you want to come in.
Thanks. I just wanted to just build on one other point in terms of Mark's answers, because I think what was also many years ago when we moved the community meals provision into schools, part of that was to form a collective benefit, i.e. schools were cooking meals, let's cook a few more meals and let's, in the aim to kind of put costs down. What that did was inextricably link us with the success of community meals to the success of school meals provision are linked. So when one starts to go wrong, both start to struggle. The point Mark made about what we're able to do statutorily, so it's not for us to buy food, it is us to buy services, and then it's us to deliver value. And I guess what we found, and Mark alluded to, was actually we couldn't deliver at a value which was felt to be fair. And don't get us wrong, we understand the importance of some of these services and the desire to keep them going, but what you also have to do is look at giving value and consistency to people, and those things all started to not go in the right direction. So the other thing we do is make sure that what we then, and I think Mark described really well, how we engage with every single person, as worried as some may be, because they would really value those services, to take them on that journey to a different way of having their meals provided. For some that's carers, for some that's other routes, but it was really important that we did that work with them to the best of our ability, and that was where the services ended up. But I just wanted to make that connection to school meal provision and community meal provision, because also with schools failing, that added potentially a new and significant burden to continue to provide those meals and costs. So the cost would have continued to go to a level which would have been, well, was unsustainable.
Thanks, Gary. I've got Lauren.
Thank you, Chair. I'm going to pick up a little bit on what Councillor Mahoney raised as a question, and then an example that Councillor Ney gave. What capacity do we have to follow up with people who we fear might fall through the net once this provision has stopped? Because we can appreciate that there hasn't been a huge amount of response in the immediate aftermath of the service being stopped, but that need might change from those individuals, say like 3-6 months down the line. Can we reach back out to those customers at that point to check in and say, hey, how are you getting on? Are you still okay? Do you need any referrals? Because I feel like as an authority, that feels like a good thing for us to be doing, to make sure that they're getting the support that they need.
The service ended on the 28th of February, which is 5 months ago. So, yeah, provided Gary's in agreement, I can send out a letter to everybody to say, how are you managing? I just wanted to add, which I didn't get a chance to just now, in the one case that our councillor friend down in the end mentioned, I just wanted you to check if that lady's applied for a social care assessment to see if she can get support for those care needs. That would be the ideal response for her. So, but yeah, I mean, we can certainly do a follow-up with all of those clients, but since February, there has been very little raised, and we've not seen any worrying peaks that we anticipated we might see in demands for social care support. So.
Thank you, Chair, but Lauren actually beat me to it on that. I totally understood where Councillor Dr Mahoney was coming from. You know, people have now been out of the service for 6 months, and that might be round about the time when they're starting to feel like, actually, I'm not sure I can carry on with this, I'm not sure I can cope. So, yeah, if Gary's agreeable, and we can have that letter sent out to those people just to do a check-in with them, and do a new referral to social services for them if need be. That would be amazing. Thank you very much.
Brilliant. Thank you, Mark. Really appreciate that. We're going to go to item 6 now, which is the Life Centre climbing wall petition.
Chair, sorry, can we take a 2-minute comfort break, do you think?
If you need to go out, Anne, that's absolutely fine. It's the fact that these people from outside, and they did come in at 2, thinking they were on at 2. So, but if you want to go out and have a comfort break, by all means you go, my lovely. Good afternoon. Paul, I understand. You're going to give a 5-minute presentation on the petition. Is that right? Yeah. Okay. I'm just going to leave it to you, and I'll give you 5 minutes.
Chair, members of the committee, thank you very much for the opportunity to speak on behalf of those who signed the petition regarding the future of the Plymouth Life Centre's climbing wall. The petitioners have asked the committee to scrutinise the lack of public engagement and transparency behind the proposed closure and act to protect and support this important community facility. We recognise the council faces financial pressures and that maintaining large facilities is costly. However, decisions of this scale must be based on robust evidence, meaningful engagement, and clear understanding of wider social, economic, and health impacts. We are not here to deny financial reality. We are asking the decisions are open, evidence-based, and align with the Council's health and wellbeing strategy while supporting community sport. Freedom of information requests indicate this proposal went beyond an exploratory case. Evidence suggests funding that could have been drawn down from the 1st of September, with completion date discussed of February half-term 2027, and redundancy costs already factored into this year's budget. This gives the impression the decision was largely made pending final approval, rather than subject to genuine consultation. There are also inconsistencies in engagement. Plymouth Active Leisure did not contact the British Mountaineering Council, the sports governing body, in November 2025 as requested. Instead, the BMC contacted them in May as per a request to its members. In the executive summary, it talks about PAL's public engagement, but in their own business case, it refers engagement as an opportunity to take criticism. This does not reflect constructive two-way process. Financially, PAL have inherited an already underfunded wall from Everyone Active, but under its management there has been little capital investment or meaningful marketing, despite the Life Centre having a marketing budget of over £64,000 in 2024 to 2025. Even so, the wall shows consistent income and participation. The argument that other facility opened justifying the closure is a weak argument. The Life Centre's busiest year was 2019 to 2020 after that venue opened, and it is also a bouldering-only facility, not comparable. Usage declined after Plymouth Active Leisure took over, but has been recovering since. The CEO has also acknowledged that the usage data has not been effectively captured, as over 100 young people attend weekly sessions that aren't recorded on the visitor numbers, which raises the question about the assumptions being made. The ward is described as losing money, but this is poorly presented. No such issue was identified in the handover notes from Everyone Active. The income remains consistent, though rising staffing and shared costs have put it in deficit. Cost allocation is another concern. Whilst floor space proportion rates is standard for business rates, but applying this to utilities and services, particularly alongside a large public swimming pool, is unlikely to reflect the wall's true financial position. Pricing is also a factor. Casual entrance fees appear to be 25 to 33% lower than similar facilities, and have been like that since Everyone Active managed the site. Sustainability may require pricing adjustments alongside continued investment in route setting and new holds, and this is part of the core product that attracts users. Climbing is one of the fastest growing sports in the UK, with over 1 million participants annually. It delivers clear physical and mental benefits and supports a wide participation. It aligns strongly with the Council's health and wellbeing strategy, as well as Plymouth Active Leisure's own objectives. The wall serves a broad cross-section of the community, including young people, schools, community groups, LGBT+ users, military personnel, active and retired, disabled climbers, and older adults. It delivers training, qualifications, social value, and supports pathways from grassroots to elite athletes, including GBT members and a world para champion. There are encouraging signs. Since the Council declined the support of the conversion to soft play, Plymouth Active Leisure have begun engaging with stakeholders. Casual usage in May and June are up this year from last, and June's daily average increased to around 65%. Many of you have visited the wall and seen both the challenges and the clear potential if the facility is properly supported. Petitioners are asking for openness, careful consideration and a commitment to protecting an asset that continues to deliver significant value to Plymouth. Thank you for your time and consideration.
Before Kate comes in, can I just ask? I'm assuming there's a climbing club. I mean, I don't know. Can I ask how many members there are? How many members have you got that use the climbing wall?
Well, in terms of externals or people who pay membership, because it's multifaceted, basically.
Well, both basically. So I mean.
So the list that I rolled off, basically school groups use it. Yeah, there are external climbing clubs that will use it. Obviously, there is the LGBT+ group that use it. There are military groups that use it. There are disabled classes that use it. There are also alcohol and substance abuse rehabilitation groups that use it. There are also youth groups, so as a product the wall does, which aren't in the participation figures. If you go in there at sort of 4, 5, 6 o'clock of an evening, there are young people all over the place using it. So it is basically, it has a large demographic in terms of what use it. And on a Friday morning, they do a discounted rate for slightly elderly people, and you can have up to, I've seen, I think one of the oldest chaps in there is almost close to 80 years old using the wall.
Kate or anybody that want to come in and.
Thanks. Thanks, Councillor Murphy. I think, do you want to...
Did you want to clarify the numbers?
Yes, go on.
So just on the numbers, so we've got 205 members with a subscription. So 205 people. So about half of those are junior climbers who pay to learn to climb, attend sessions every week, and the other half are casual climbers. That's 205 people who pay every month on a direct debit.
In terms of individual registered users since April, there's about 450 individual users. So that could be people using it casually. That includes the 205. I'd say that is registered. So to be open, you know, a school, we might not have every single, if it's 30 in a class, we might not have every single 30 individual registered as a child. But in terms of our registered users, it's about 450.
And I understand that there was a question that was asked. I don't know if that question wants to be asked now, before we go any further.
Oh, thanks, Paul. It's summing up a little bit of the end of Paul's speech. So just know that the decision has been made to save the climbing wall. Will the council commit to developing it not only as a valued community space, but as a flagship sporting venue that Plymouth can be proud of?
Do you want to answer that one?
Thank you. I'm hoping that I can cover the answer to that question through both what I'm going to say now and through the course of the discussion rather than duplicate. And I wrote my opening remarks before obviously heard your speech today, so forgive me if I duplicate anything or don't fully address stuff. Hopefully it'll come out in questions. I wanted to start by acknowledging why we are here today. It's very clear that the climbing wall means a great deal to a lot of people. Throughout this whole process, we've heard from climbers, from families, from volunteers, from people outside of the city, all who care immensely about this facility and what it means to Plymouth. I don't think that passion has ever been in doubt. But it's important to remember how we arrived at this point. Earlier this year, PAL, when we worked through the wider business planning, was exploring a number of options to improve the long-term sustainability of the Life Centre. So it wasn't specifically about the climbing wall. One of the options was a potential redevelopment of a climbing wall as part of a bundle of other potential business cases. PAL did exactly what we had asked it to do when we extended the contract, challenge itself, examine those different business cases and look at ways to make the Life Centre financially sustainable whilst widening participation. But good decision making means listening to people. And when the public consultation began, the feedback was huge. I received so many emails, tags on Facebook, comments, phone calls, representations from councillors across the council, climbers, stakeholders, all people that care about this issue. And having listened to that feedback, actually took the decision early, before the end of the consultation, with Reece, to not proceed with the proposal to close the climbing wall. And I believe that was the right decision. I think good governance and good decision making means listening to people, and I try and be the sort of politician that I want to see, not one that puts their hands over their ears and ignores what was obviously a very big strength of public feeling. However, retaining the wall is not the end of the conversation to me, it's the beginning of a different conversation. We know that the facility is valued, but we also know that it has to become more sustainable for it to thrive in the long term. We can't preserve the status quo. It's not enough if we want people to continue to enjoy use of the climbing wall for many, many years to come. And that's incumbent on all of us. And Reece is the Chief Executive of Plymouth Active Leisure, and I'm the portfolio holder for the local authority which owns the company. We are separate, but we're together. We're a team. Because a local authority training company is owned by us. It's in all of our interests, as a council, as a portfolio holder, as a chief executive, that we deliver the strategic aims both of the council and of PAL. So Reece and I have worked together to move forward from the point of, in my view, and I hope that Reece would agree, the closing of one chapter and the opening of another. I facilitated conversations with the British Mountaineering Council, with Reece, so that we can bring together some of that expertise and ideas and explore opportunities for the future of the facility, rather than allow the discussion simply to end at the stage of the decision not to close it. noticed and I hope everybody has noticed, a marked increase in social media and marketing of the wall, which was an early request from me, because I think we took on the chin the criticism that the wall hadn't been promoted in the same way as other facilities at the Life Centre, and that was taken back. And I actually scroll through Facebook now and see regular posts about the climbing wall, which are now well engaged with, which I think is positive. Plymouth Active Leisure is not an external contractor. Its success or failure is not the business of other people. It is ours. It is a local authority trading company, and for that reason, I want it to succeed. And equally, I want the climbing wall to succeed, and part of this role is balancing those two responsibilities. So I would like to be able to move forward the conversation rather than revisit a decision that has already been made, that I obviously took on the chin at the time. The wall will stay, and I can make a commitment for as long as I'm the portfolio holder that will be the case. I can't tie the hands of future administrations and future portfolio holders, but I can make that commitment. So very open to questions, which Reece, Steve and I will work to answer. But I'm looking forward to working together to move forward with PAL, with the council, with the climbing community, with national partners and interested parties and users to increase participation, but most importantly, improve the sustainability of the wall so that it remains for many years to come in the future. Reece, I don't know if you want to say anything?
Thanks, Councillor. Thanks, Paul, for your words. I think we've done a lot since when it was the 1st of June, and now we're firmly in the space of making sure we can make that climbing wall as good as it possibly can be. It's going to be a long road. I don't want to sort of get away from that. You know, we really need to do a proper review of that facility and what we can do and what the opportunities are, and work with the community. We've already started to do quite a lot with that. Councillor Taylor talked about the national governing body. We've met a steering group, done quite a lot to try and learn about that, and talking to other experts around the industry. So, you know, we want to learn from the community and make sure that we're able to deliver that. So, absolutely, I'm committed to make sure that happens. That's the direction we're going in. So that's what I'll do. I'm really looking forward to working with Paul and all the other users to make sure we get there.
Vanessa? Thank you, Chair. Please, could we have a copy of your report? I would give it to Paul Riley, if you could. Also, who pays for the advertising of it?
Actually, Vanessa, it'll go to Elliot and Leah District.
Oh, that's fine.
To everybody.
Yeah. Who advertises it? Is it who spends the money to advertise it on it all?
Plymouth Active Leisure.
Active Leisure. Because I've never seen it before. I've only realised what it was when all this came out in the open, because I've never heard of it. And when I went to the Armed Forces Day, I was surprised that the queue was longer than this room of all the people that were trying to get up it. And I think it's a brilliant thing to keep. So I would like to see it stay. Thank you. Thank you, Chair.
Lauren?
Thank you, Chair. Councillor Mahoney's actually advised I maybe declare an interest because I am a climber at the Life Centre. So this item is quite close to my heart. And I think maybe to start, I just want to acknowledge some thanks. So the campaigners who worked really tirelessly to bring this item to the attention of the council and to advocate so brilliantly for the wall in the space that they really treasure. It was really welcome. I also need to thank both Reece and Councillor Taylor for their response to this. I appreciate that it's really difficult and sometimes to listen to that feedback, but I think you've both handled this with a lot of respect and forward looking, which I'm personally really grateful for. So I think in the spirit of moving forward, of looking ahead to see how do we safeguard the space and make it as best as we can, because I think it's really important to note that climbing is incredible. as a user, it's not just a kind of physical activity. It's really mentally stimulating. It has a brilliant community behind it, and also it has growing number of people participating in it. It's also an Olympic pathway as well. So by closing down that wall, we were closing down opportunities for future young people to really make Plymouth proud. So in terms of a couple of recommendations, I was really grateful to be shown the space by Reece and team members last week. There it kind of became quite clear to me that although Reese and the team are really passionate about the space and making it work, they don't necessarily have the expertise in climbing behind them to make it work. So how can we support you in making that happen? The recommendation I had in mind, and you will forgive me, I'm not sure if it's within my gift to ask it or not, whether there might be an opportunity to appoint a board member with climbing experience to Plymouth Active Leisure in order to support that work. Then kind of like building back from that, I've heard kind of conversations about a working group, so working with staff, users, the council, and outside expertise. What does that look like? What are the outcomes of that going to be? So will we be looking at some sort of strategy and recovery plan? If so, I'd really love for something like that to come back to this scrutiny in 6 months' time, so that we have benchmarks and accountable KPIs for the wall, so that we know what it takes for this space to succeed and what that actually looks like for PAL. And then another recommendation that I had was looking back at the KPIs that were presented by PAL at the cabinet meeting in February, I believe, and then at committee in December. There was nothing in there relating to the climbing wall, and I think there's a real potential to weave some of that within that governing document. So particularly in that Inspiring Plymouth section around young athletes, there's a goal for diving, but none for climbing. So I wonder if there's also an action there for you to go away, have a little bit of revision of those KPIs to make sure that they're inclusive of the full offer that Plymouth Active Leisure offers in terms of activities.
Thanks for that, and thanks for your support. You know, I know you're passionate about climbing, so it's just great to have you here. It's quite a lot in that. I suppose what I'm nervous about is providing any timelines on this, because I think we're at the stage now whereby we need to do a really thorough review of what's going on in that space, and you know, happy to come back and bring what we find. But I think we need to sort of rebuild now and almost start again to make sure there's strong foundations in there. So I don't know. I don't really want to put a time on that. I want to do it properly. Having said that, there's absolutely some quick wins in terms of, you know, marketing and making sure there's other things in place, which that's well underway in terms of a foot. In terms of the KPIs, we do a lot of different sports in the Life Centre. So it was a question that was put to me at the steering group last week for the climbers. Swimming is named in our strategic plan. Swimming is named in our strategic plan because as the ocean city, there's a city that it's got a lot of heritage around the water. We also signed the first MOU in the UK with Swim England. So Swim England, so no one else in the whole country as a city has signed an MOU with an NGB in that space. So we were the first to do that, and they provide us financial backing and support around training, qualifications, events, and it's kind of a really rounded MOU with that. So climbing will fall into our strategic plan. I mean, actually, I'll quote you, which is great, you didn't know, but you actually quoted one of our strategic aims in what you just said. So one of our strategic aims is making Plymouth proud. So, and what falls within that strategic aim is events, creating pathways to the Olympics, giving children the opportunity to experience sports. So we can absolutely, and I did commit this to the user group last night, we'll come up with a climbing plan. You know, like we were doing an aquatics plan. You know, we can come up with a plan for climbing, which again, I don't want to put any time frames on, but I guess what I'm saying is that will fold into our strategy naturally. We do lots of sports. We do gymnastics, we do octopush, we do, so I could reel off dozens of sports, and they're not all named in the strategic plan. However, it doesn't mean we don't give them all attention. I appreciate this has come up, so you know, I suppose I give my assurance that we'll absolutely drive it, because that's what I've been tasked to do. So I will. And Paul's right when he talks about Olympians and that being, you know, making the city proud. We want to do that as well. So one big thing we're focusing on is children and young people, because I mean the city's got place-based money coming in from Sport England, so I think there's an opportunity there. You know, how do we get more children involved in climbing, which then fills the funnel? You know, more children involved in it, more opportunity going up. So I think that's something we need to immediately look at, and the game plans are afoot with the NGB to do that. We do it in swimming. You know, learning to swim is one of the things that goes into competitive pathways, and even just dangling your feet. I've just been over the Lido, it's packed. So it's, you know, around that pathway into other opportunities. So you know, the Life Centre could become a pathway into climbing or outdoors or Dharma or whatever it might be around that grows green and blue spaces. So I guess what I'm saying to you is I'd be nervous to put anything specific in the strategic plan, but it is already in there as well. But again, open to challenge on that, and given my assurance, you know, we'll drive what we need to do in that space.
Can I just?
Can I just add to that,
Yeah,
Chair?
of
Is that
course,
okay?
yeah.
So for committee awareness, we're due to come back to committee in December anyway to provide an update in relation to KPIs. So if the committee is permitting, I would suggest that we bring an update to that session rather than set two parallel processes in place. So I think I absolutely support everything that Reece has said and take on board the points you've made, which are very realistic and valuable contributions. So I think we can take that back through the PAL board to work out how we make that into a bit more of a firmer reality, but to give some timescale in relation to helping us to expedite some of those conversations. Thanks.
I'll get Carol. It's just a thought from me, as with my Armed Forces Covenant head on, and you say that veterans use that climbing wall. Maybe you might like to explore the Armed Forces Community Grant Scheme so that you could get some grant towards that climbing wall. It's just in my head because you did say that like veterans do use it. So it could be that if you fill in an application form, you might be able to get some funding to help towards that. It's just in my head. Carol.
Thank you, Chair. Lauren, actually, Councillor McClay stole part of my question because I was going to say we need a PFI performance report as we go through the year. But I think it's important to recognise that major decisions like these can't be made behind closed doors by an executive committee. They really do need to go out to public consultation. And I know there was some kind of consultation, but it was very biased, and it was, in fact, we're going to do this, close it down, but we're going to give you a soft play area. There was no unjustified consultation for people to say, how much do you use it? What do you like about it? Is it worth keeping? And I think that's something we need to learn by.
Chair, I would just add that there was a democratic process around all of this. So PAL has its own board who make decisions in relation to PAL. I worked with Reece to stop the closure of the board, closure of the wall, but the board is separate. I do not have any role in the board. Nor do I think that the council in general and particularly executive members should get involved in the operational running of a arm's length company. There's a reason why not just PAL but also DELT as another example have chief executives and boards and staff, because it is not the role of a cabinet member to run an organisation. You know, they're very clearly defined roles, which actually was quite a lesson during this whole process, actually, because a lot of the grief during when the proposal came out was directed at me. Actually, some of it was quite horrific actually, and it wasn't actually technically my decision at any stage of the process. And the paper that came to scrutiny was around the contract extension, which the climbing wall is part of the Life Centre, which is part of a wider group of facilities run by Plymouth Active Leisure, which is one of our local authority trading companies. So at every stage you get further away from the decision-making processes around those things. So we need to be clear, and Reece and I are clear in our roles, but it might be helpful perhaps for us to outline as part of further things that we bring to scrutiny, actually what is within the remit of the council and elected members, and actually what is operational. Those are two very different things, and I wouldn't want us to stray into that. But the papers, the paper that went to cabinet, of course, is published, and all members are more than welcome to look at those papers, ask questions, come to cabinet, and raise concerns. It's open to all elected members to do that, which many did, including Councillor McClay, rather than wait until after the fact.
Will.
Obviously, sort of, I think maybe what Councillor Taylor's just sort of talked around there, actually what our involvement is as councillors regarding Plymouth Active Leisure, its predecessor SLM. I worked for them, but you know, the PAL was set up with a different ethos to sports leisure management, and then it was contracted, the actual wall was contracted out again to a company that gave that up in 2017, 2018, which was a specialist company. And then we've got to do also the things with some of the niche, lots of sports. You had the pandemic and the stoppages there, and that can stop, especially places like universities. A big, I mean, I played water hockey, and the university is a big source of players, especially people that go from youth players and then go into people I played with at university years ago now run the national association. So what was the question is what can we, how can some of that setup be made clearer to people, so you know, the plan going forward is made clearer where the involvement is, and how the strategy for the overall life centre and the climbing wall, and what if we need to revisit this issue like 2018 when they pulled out, you know, this could happen again if the, you know, the wall just isn't viable. We hope it's not going to be, but what happens if we get there again, and you know, that becomes a liability that you know starts to affect the rest and unbalance the rest of the life centre.
Yeah, thanks for that. I think I'll go back to what I said earlier about doing a proper thorough review. So we need to really understand what the kind of limit is. The good thing is we come here with lots of things we can do, as opposed to exhausting all of the things. So I think we need to get to that point, which I'll kind of call, you know, the base, if you like. So once we've done everything right, you know, we're marketing it properly, we've got, you know, the program's visible online, the product is right, the program's right, all those things are right. You know, we'll see where we're at then, I think. So hopefully we can make it work, but I think we need to get to that point first and do that proper review and see where we can get it to.
Paul?
Just a quick one. When you do your review, you're going to have all your ideas and you have pretty much a business plan, a complete business plan, I hope, that you're going to have there. I hope it involves the finances as well. Yeah. Of where you're going to get the money, how you're going to get the money, who's your partners, that sort of thing, and who's supporting you throughout that. I think that will be helpful to, and your predictions as well. Like any other business, you've got to do a full business plan.
Yeah, absolutely. I mean, Paul mentions pricing. We need to have a review of product pricing, people, the whole work. So I think what we'll do is go right way through that and make sure that we got to, you know, see what we can do, the impact of that, and where we think that you know, there's almost like a phase 1, phase 2, phase 3, and see where we get to with that. So absolutely, financials will be very much part of it.
Ray?
Thank you, Chair. I think somebody said the other day that the footfall had doubled since this time last year. How sustainable is the wall at the moment as things stand today?
I'm not sure about the stats on attendance, but I did have a quick look. So we're forecasting the wall on its own for the first quarter, so April to June, is going to make a loss of about between 10 and 15,000. That doesn't include any utilities. I know there's a discussion and contention around how we're allocating costs. So if you take any utilities out altogether, we think it's going to make a loss of about 15k so far. So it is we're going into the quiet period now. So really everything we're doing is gearing it towards September, October. We're doing some work around children and young people on something called Nightcast, which drives young people through it. We've got the youth event, which BMC do every October. So we're using that as the launch. So the vision is that we use that as a kind of a springboard to get lots of young people involved, try and get them to come in and join on a lesson and see where we can get it. So over the winter, and then the students coming back, we need a really good season with the students. So, you know, September to January is really critical, I think, to this, in terms of we need to have our pricing plan ready, our program ready, everything ready for that time, and that's what we're kind of heads down full on trying to get towards at the minute. So I think, you know, coming back in December is timely, because I think we'll have moved quite a long way ahead of that, working with the users and the national governing body in that space.
Sorry. Has anybody else got any questions? Yeah, one.
So the number of regular users is pretty low, isn't it? You know, in a city of this size. Do we know how many of those people come from outside of the Plymouth Local Authority area? And whether that could be, the reason I'm asking is, I'm thinking about pricing when you're looking at that, and whether I'm sure you're already thinking about that, aren't you? Two different charges, which will maybe be very unpopular with some people, but it is a council funded resource. We need to think about that. Yeah.
So thank you for raising that, because that's a really interesting point, and I did discuss it with the youth group last week. What's constantly come out of this is a regional venue. I make no apology that I'm focused on Plymouth, the city of Plymouth and its residents. So if we've got people travelling hours to use the climate, which is great, but yeah, we do it at Tinside, so we have a residence and a non-residence price. So there could be an opportunity whereby we do that. So if people come across and we charge that. I mentioned Swim England, again, talking to the national governing body, again, regional venue. Well, we need some support to maintain a regional venue. We get a lot of support from other NGBs around that, whether it's exposure or money or training, access to training. We don't get any of that at the moment, other than them bringing their event thing. And I've had that conversation with the chief exec. So we're on the same wavelength for sure. Yeah. In terms of the data, we have got that data, but it's something that's constantly being pushed to me.
Is there any more questions? No? Okay. Sorry. So your response was for the call on the council to halt the proposed closure of Plymouth Active Climbing, which has happened. It has happened. And then you obviously want to take action to protect and support this vital community support facility used by residents across the city and the wider Devon and Cornwall region. As a panel, I think what we need to do is ask Pearl to come back with their KPIs and performance in December 26, give us a progress review and to ensure that the appropriate action is ongoing. And I think that's what our recommendation will be today. With all due respect, Lauren, to have somebody sat on the board, I don't think I'm not going to take that as a recommendation as a chair, because there's so many things that go on up at the life centre. If you start doing that, then there'll be like, oh, we need somebody from the swimming sat on board, or we need somebody from badminton sat on the board because of whatever. So that was in my own mind. I don't think that would be appropriate at this point. But I think to come back with some indicators in whatever in December, I think that's what we'll do. Is everybody happy with that? Yeah, go on. Yes. Yeah. Okay, lovely. Thank you so much for coming in and giving us the time. And I can see that you're really passionate, but also I think we need to thank Pal and Cabinet Member for responding to this. They didn't take it lightly. It is a very big decision to make, especially when Reece has just said that it has made a loss. It will be a loss of £15,000, which is a lot of money. So I do thank Kate and all the team for reconsidering and overturning that decision. So thank you. We are now going on to item 11, which is drug and alcohol services deep dive. And we've got Kamal and Maria, and I think we've got you, Steve. Yeah, you have something. Oh, I don't know about that. Yeah, that's right. If anybody wants a quick 2-minute break, go now. Jenny. I can't see, love, without me. I can't see that far with my glasses. So I'll leave it to you to start.
I'm going to start, thank you, Chair. I'm pleased to introduce this briefing on drug and alcohol services in Plymouth, which provides an overview of local need, system performance and progress against the National Drug Strategy. Substance misuse remains a significant public health challenge. The harms extend well beyond individual health, impacting families, communities and wider systems, including housing, criminal justice and mental health. Many people affected experience multiple disadvantages such as trauma, homelessness and poor physical and mental health. Plymouth faces a higher level of need than the England average. Encouragingly, we are seeing strong engagement with treatment services, with over 2,200 adults in treatment last year and rising demand reflecting improved access and capacity. Our adult drug and alcohol system is delivered through the Plymouth Alliance for Complex Lives, bringing together drug treatment and housing providers to provide a more joined-up approach. The Specialist Service for Children and Young People is run by the Children's Society, and there is strong partnership working across the system to support children and young people. This partnership model is supported by the Plymouth Drugs Strategic Partnership, which provides oversight, governance and accountability across the system. There are a number of positive areas to highlight. Plymouth is performing strongly in getting people who use opiates and crack into treatment, with some of the lowest unmet need nationally. We have also significantly increased treatment capacity, strengthened the workforce and expanded harm reduction initiatives such as naloxone distribution and an overdose response team. However, there is also important challenges. We have seen emerging risks from synthetic opioids and nitazenes, and alcohol-related harm remains a concern. In response, the system is taking a strongly preventative and whole system approach, investing in early intervention with children and young people, strengthening links with mental health services, improving continuity of care from prison and hospital settings, and addressing wider determinants such as housing and employment. Overall, this paper highlights both the progress made and the areas where further improvement is needed. It demonstrates a system that is increasingly collaborative, evidence-based, and focusing on reducing harm, improving recovery and tackling inequalities across our communities. I look forward to the discussion. Thank you.
Thank you, Councillor Lawson. So you have the paper in your pack. I also do have a presentation that kind of is a summary of the paper. I'm happy to go through that or not, depending on the kind of preferences of the chair and the board, the committee.
I'm quite happy for you to go for it, Carmel.
Yep, okay, thank you. So, So as Councillor Lawson has just outlined, we have significant individual and societal harm associated with drug and alcohol dependence across many areas of society. So poor physical, mental health, discrimination, poverty, violence, offending and homelessness. Nationally, drug deaths in England have been rising since 2014, and that led to the previous government producing a national drug strategy, bringing together the enforcement and the health elements of drug use. As part of that, each area set up a strategic drugs partnership, which is the central body for reporting and oversight and accountability of the local delivery of the drug strategy. So we have our local drugs partnership with a wide range of partners across the system, across different sectors as well, in terms of the police and Safer Plymouth and others all there, in order to bring that work together and focus around drugs and alcohol support. So looking at our local needs, nationally there are produced estimates for based based on research and modelling. These are produced nationally for every area around the estimated prevalence of people who use drugs and alcohol, and broken down by the type of drug and alcohol. So as you can see here, in Plymouth, there's estimated of almost 1,900 people who use opiates and or crack, and broken down below there in terms of whether it's opiates only, crack only, or both. And about 3,500 people are estimated to be alcohol dependent. So comparing that to national rates of alcohol and drug prevalence, the OCU, so opiate and crack use, rate is 24% higher in Plymouth than than England, and alcohol dependency is 20% higher in Plymouth than in England. In terms of our local provision, as Councillor Lawson said, we have the Plymouth Alliance for Complex Lives, which provides the treatment for adults. That brings together housing, homelessness, and drugs and alcohol provision. So in terms of the drug and alcohol provision as part of that, we have Harbour, who are main providers of the psychosocial interventions. We have Hammer's House, who provide a structured daycare intervention. And we have Live Well Southwest, who provide the complex needs team. So that's all the clinical elements of drug treatment. So prescribing, mental health nurses, psychologists, detoxification, prescribing, etc. And our young people service is provided by the Children's Society. So our local data shows that in terms of numbers in treatment, we have about 2,400 people in treatment in Plymouth across all the different age groups and so adults and young people. Yeah, as you can see there, we've got about 1,300 people who use opiates and or crack in treatment, about 400 people use alcohol, and then the non-opiates are other drugs like benzodiazepines or ketamine, etc. Unmet need. So unmet need is the percentage of the estimated prevalence of people who use drugs and alcohol who are not in the treatment. So a lower number is better for unmet need. And for opiates and or crack, we have the second best rate of unmet needs, the second lowest, second best. So in Plymouth, only 33% of the estimated people who use opiates and or crack are not in treatment, whereas nationally that's up at 54% there. So out of the 150 or so local authorities, that's the second lowest. And then for alcohol, our rate is more in line with the national average there in terms of quite significant unmet need nationally and locally, around 77% there. Treatment progress. So this is the proportion of those in treatment who have successfully completed treatment or who are still in treatment but drug-free or have a sustained reduction of their drug use. Our rate is 43%. The Plymouth average is about 47%. The England average is about 47%, so slightly lower, but in line. And then looking at outcomes for young people, these are the ways that these are measured nationally. It's the proportion of people still using those drugs having been in treatment. For Plymouth, alcohol is NA because we don't have people in treatment for alcohol, but for cannabis, we have similar rates of improvement to national, and other drugs such as ketamine, we have in better outcomes there, and particularly around unmet need for mental health treatment in our young people's cohort. And that's due to the deployment of CAMHS workers directly into our drug treatment service for young people. Continuity of care. So this is a measure of people who leave prison with a drug treatment need. So they're in drug treatment in the prison, but when they get released, what percentage of those are picked up by the community drug treatment within 3 weeks of release from prison, which is clearly an important thing for their health and to reduce reoffending, and a key priority nationally. So as you can see, we're kind of in line with the national average there in the kind of mid 50% in terms of that measure. These are the measures that are nationally kind of used as kind of the key signals to how the system is performing. Drug deaths. We have two measures of drug deaths related to drug and alcohol. So first we have drug misuse deaths. So that's the national ONS statistics based on death certification. And so that's a post-coronial process. So our rate is in line with the national average there for drug deaths. However, it's like, I put an asterisk by it because it's likely, although we don't have specific data to show it, that some of those, the reduction in Plymouth is due to delays in the coronial process. And we see that with our suicide rate, which we get specific data on. We don't get specific data on the delay for drug deaths, but I'm making a reasonable assumption that that's caused a reduction in our drug death official rate. The other measure is drug deaths in treatment. So that is anyone who is in treatment and dies of any cause. So that can be drug and alcohol related cause, or it could be a medical cause of any other kind. So you can see there that our rate in Plymouth is higher than the national average. There's a couple of reasons why, and has actually increased in the last year, and I'll just kind of go into that a bit more. So I think there's a couple of reasons why our rate will always, not always, why it may be higher than the national average. And part of that is because we have a higher number of people who use opiates in our drug treatment. That's a good thing, that we've managed to access more people who use opiates. So when and if those people have an overdose and unfortunately die, it's more likely that they'll be counted in the deaths in treatment statistic because they're in treatment. So that's one reason. And we have also have a higher, we know that from our needs assessment, our age of people in treatment is higher in Plymouth, the average age of people in treatment than national. And in terms of kind of polydrug use and kind of more complexity is also higher as well. The increase in this year or the last year is likely due to we did find nitazines, which is a synthetic potent opioid in our local drug supply earlier in the year, and that is likely to contribute to a higher rate of drug deaths in the early part of this year. Alcohol deaths. This graph compares the Plymouth rate in green to the England rate in purple, I think. And it kind of shows that the Plymouth alcohol-related deaths is at the moment higher than the national average. It fluctuates, and I think that's kind of testament to just generally, it's just a statistical phenomenon around generally there are low numbers, and therefore changes, variation throughout the year can cause a significant impact. As you can, that's by the size of the confidence intervals there, they're always, although it gets close at some points, they're always it always encompasses the national average within the confidence intervals of ours. We also have a higher number of people who are alcohol dependent, 20% higher prevalence of alcohol dependence in Plymouth. So there's increased need there. So going into so that's the local need and performance. Then in terms of finances, so Plymouth is in receipt, or all areas in receipt of a ring-fenced drug and alcohol budget, and this is a separate ring fence within the public health grant ring fence. So it's a ring fence within a ring fence, and for Plymouth that's £7.3 million per year. And that's broken down in terms of how that's spent. So our Complex Needs Alliance contribution from public health, so that contract has contributions from other sources for the more housing elements, but the public health contribution is 3.7 million, and the budget for the Children's Society Under 18 service is £250,000. We also have other costs around, so included in that ring fence is staffing costs, so my team's time, as well in terms of the commissioning and system leadership, and then also other budgets such as detoxification budgets when people go to a residential detoxification service, and then what I've put there is the MCDA prioritised allocation. So that's the multi-criteria decision analysis prioritised allocation. So that was previously the Drug and Alcohol Treatment and Recovery Improvement Grant. You might have heard of that, DATRIG grant, which was the extra grant that the government gave us after the drug strategy to say, drug deaths are going up nationally. Here's, the review has shown that actually there's been a reduction in drug funding from 2010 down to 2021 when they made their strategy, and so there was an extra allocation nationally for each area to kind of make up and make improvements and reduce drug deaths. So that was the 2.8. But now that's this year, as of 26-27, that's been incorporated into the main grant. And so it's still treated separately locally because the other money is kind of strongly committed into the contracts, whereas the grant money was a year-by-year thing, so it wasn't as committed. So that's why we undertook a multi-criteria process to allocate that money with the 3-year settlement that we got from the government last December. I'm happy to kind of go into that more detail later if needed. That's just showing that as percentages. So this looks at the next section of the report looks at the priorities nationally around the drug strategy. So the headings of each slide is one of the national priorities around it. So the first priority is delivering a world-class drug and alcohol treatment and recovery system. We've significantly improved our capacity through the additional grant. So we've got about 500-600 people extra in treatment following the receipt of those grants. Quality of treatment as well. We've reduced our drug deaths although it increased the year from the last year to this year, there was a reduction since 2022. And we have a treatment subgroup from the Alliance contract, which focuses on treatment, and a co-designed action plan based on 8 priorities, which are based on local priorities and the national priorities together. And they're outlined there. The really key aim is that we collaborate across the system to deliver those. In terms of drug-related deaths, we have a local drug information system. So that's run by Public Health, which is there is a form that our partners are aware of in the city that people can submit if they are suspicious of there is being potent, adulterated, contaminated, or synthetic drugs. So they would fill in that form, and that would information come to us. We would assess that, and we'd pull together if required, pull together a panel of clinicians from the hospital, from the police, and from the drug treatment providers to review that information in line with the Office for Health Improvement and Disparities guidance around that, and make decisions on what action to take, including potentially issuing a drug alert. We have a synthetic opioid response preparedness plan, which looks at the mitigation and the response to if synthetic opioids are found in our system that we utilised earlier this year. We have loads of naloxone programs, including a peer-to-peer naloxone program. Naloxone being the antidote to opiate overdoses. And we also have a Plymouth overdose response team, which receive information about overdoses, particularly from our hospitals, because we know that non-fatal overdoses, because we know that people who have non-fatal overdoses are in increased risk of a fatal overdose within the next 28 days. And so that's a way of rapidly getting those people assessed by our drug treatment service if they're in it or not yet in there. Alcohol work is led by the Alcohol Steering Group. The additional funding from 2022 enabled us to develop our specialist alcohol treatment team at Harbour. We've also looked at lots of elements of that pathway. So one of the key elements is around hospital discharge into our drug treatment services. So we've done a lot of work on the old system was that people would be discharged from the hospital with advice to go to Harbour and go and support themselves. But actually, we now have direct referrals in from the hospital into our drug treatment, so that the people with the highest need can access it. And there's lots of other examples of good systems. We know Hammer's House are currently running a test and learn pilot with the hospital to even further enable that rapid access pathway from the hospital directly into their services. we're looking at licensing procedures, so we wanted to make sure we're involved in responding to licensing applications around alcohol premises, using our information that we have around where the harms are, and feeding that into the process. We developed an audit standards for alcohol treatment based on the national guidance, and we're also developing a intramuscular thiamine offer, which is essentially concentrated vitamins that you can use for people who are alcohol dependent to reduce the risk of alcohol-related brain injury. Inpatient and residential provision. So inpatient, I mean not hospital inpatient, but a residential facility that would do a medically assisted stabilisation or detoxification of someone who uses drugs or alcohol. We've really improved that process in the last year with really clear clinical oversight, a multi-agency detox panel, Hammersmith House providing pre and post detox support. We are now, that was the inpatient, that was the detoxification process. We're now looking at the stabilisation process. So people who might be on methadone or need to be on methadone, for example, as an opioid substitution therapy and need a more intense treatment to stabilise themselves on that treatment. So we're currently reviewing that and want to integrate that together with the detoxification panel, so it's all one panel. We've seen an increase in residential rehab placements through the work of our substance misuse adult social care team, who are based in Harbour and provide that kind of specialist social work element. And that's all coordinated through that Live for South West team. Workforce is a key priority nationally and locally, and we kind of undertake, we have a workforce development coordinator in progress who works across the Alliance, not just in drug and alcohol treatment, and actually wider than the Alliance as well in other related services, to provide suicide prevention training, assist training, embed trauma-informed approaches, kind of developing that pathway approach. And we've also recently started trained workforce wellbeing champions within our services as well. And this is, we're using the alcohol and drug capability framework, national framework, to do that. The integration of services, that's around, the theme that I've talked about around, mental health, housing, all these other aspects that contribute to someone's life and the position that they're in. We've worked on improving the link up between those areas. So we have a really robust clinical mental health and psychological offer within Live Well, who contribute to MDTs, provide clinical supervision to partners across the Alliance, and access to therapies as well. The Health Inclusion Pathway Plymouth is an ICB funded project which provides wraparound mental and physical health support for people who are have complex needs and frequently attend hospital, but they're well linked in and integrated to our service. Our drug treatment providers provide drop-ins, clinics, and our clinical providers provide that into hostels, so they go directly into hostels to do that. We have a homeless intervention team for Harbour who particularly work with rough sleepers, and we also have an individual placement and support programme, which is at Shekinah, which is for access people in this cohort to access employment, and we know that actually our local data shows that that is outperforming nationally, as in we're outperforming the national data on that in terms of supporting people into employment. Criminal justice.
Come out.
Yes.
I'm going to stop you there because I'm going to get members to ask questions. We've had the report, so
that's fine. That's fine.
I don't mean to be rude when I say
fine.
that, but I think what we'll do is that because it's getting hot in here, we'll go to questions. Are members happy just because you've had the report? Are you all happy to go to questions? I'm going to start. Come out. Can you explain how funding is distributed across the organisations delivering drug and alcohol services in Plymouth, and what criteria is used to allocate those funds, and how we ensure that funding reflects local need?
Absolutely. So So there's the core contract from the Alliance, which is part of the contract that was established in 2019 as an Alliance contract. So that's, that funding that we get, so there's a £7 million contract, 3.7 million comes from public health. That money is allocated by the Alliance leadership team. So the Alliance leadership team, which includes the CEOs of the 7 organisations, or the leads of the 7 organisations as part of the Alliance, and Plymouth City Council, Public Health, Commissioning and Community Connections in that. So that money is allocated from the contract via the Alliance leadership team. So those decisions for that core funding is made through that process. And then in addition to that, since 2022, we've had the additional grants. So that additional grant has come into the public health budget. So that funding is allocated through public health. Since the start of that funding, the process for allocating that funding was a collaborative process. So I started after that that had been completed, but with the additional money, the process in which that was undertaken was through the treatment subgroup. What are the system requirements? There was a needs assessment involved in that as well, in order to make those decisions about how that additional grant money was spent. The fund, since we got the 3-year settlement from the government in December last year, we in Plymouth had a reduction in funding for the additional grant money. So although it was a modest kind of, over the 3 years, 300,000 reduction, most areas saw an increase because of inflation. So if you add inflation into that, you get to kind of £600,000-700,000 reduction in Plymouth, and that's been challenged. And the rationale I had back was because they gave us a bit too much in the first place, but that's fine. So in order to manage that budget over the 3 years, we undertook a multi-criteria decision analysis process. So we we transparently set a process that we shared with partners before doing the process. So we outlined 8 criteria that we wanted to assess where the funding is currently going to from the grants, and also additional priorities that were being raised to us based on the data and the local need. So we looked at statutory or mandatory requirement. What is that? Is that service a statutory mandatory requirement? What's the impact of the range of services on drug and alcohol related deaths? What's the alignment to the evidence base and the guidance? What's the strategic alignment to the local national priorities and ambitions? What's the impact on populations experiencing multiple disadvantage? So not just drug and alcohol. What's the reach of that funding in terms of its relation to costs and unmet population need? What's the impact on safeguarding vulnerability and the contribution to prevention and early intervention? So we used those criteria, which were agreed before the process was run, and agreed with the council at the time, Councillor Aspinall, and Public Health, and OHID actually as well reviewed it, and we're happy with that. So then we used that criteria to assess where the current funding is going and the additional priorities to essentially decide how the funding was allocated for the next 3 years.
Just to follow up on that, so how do you compare you've done all of this, so the actual performance, how do you monitor that? And if they're not, so where this money's been allocated to Hamos, to Harbour, to wherever, and they're not performing, and they're not actually performing what they should be doing, how do we address that with the funding? So I'm assuming like Harbour, they have to have some performance, and if they're not reaching that target or whatever, do we pull funding and allocate it somewhere else, or what happens if they underperform?
I think that sits in kind of standard contract management. So we're not in that situation. So
We're not.
We're not in that situation. So if you look at us compared to national in terms of the key data that I've outlined there around numbers in treatment, we've increased our numbers in treatment more than national in terms of percentage. As I said, we've continued to have a low level of unmet need for opiates. And I think that's testament to Harbour that they can reach almost 70% of people who use opiates in the city into their service compared to nationally reaching under 50%. That shows, I think that shows quite a lot. Things like continuity of care. I showed in the stats that it's been level from last year to this year, but if you go back 4 years, we were down at 20% compared to nationally at 50%, and we've now upped that to 50% over that time. So there's really key performance indicators that are improving and showing good performance. There's loads, obviously there's lots of, there's always going to be places to improve, but through the specification and contract management and indicators, we monitor that and would work through that as we go. In terms of the 3-year settlement as well, when we did the process and allocated the funding, the first year was confirmed, so the year we're currently in, but the next 2 years were indicative funding, so we will undertake a review process again this year to confirm the funding for next year, but we gave the indicative amounts because that's helpful for service, to forward plan and organise that service rather than doing it yearly.
Can I just, I've got the list here, there's like where the budget is, like Harbour, Live Well, Community, Hamo, Shekinah. Is there a reason why Trevi's not on there?
So Trevi aren't in the alliance is the first element of that, but so it's a good question. So in terms, our commissioned drug and alcohol treatment service is the Plymouth Alliance for Complex Lives, so that's essentially why we've.
I'll get that come out. So is there a reason then why Trevi are not part of that alliance?
So Trevi are not part of the alliance. I don't know why they're not part of the alliance. It was, that work was done before 2019. But they are part of our treatment subgroup, which is an alliance or subgroup. We do invite Trevi into that group. So actually, we have other partners around the system who aren't just alliance partners. So they are contributing to the system and how we support that. But they're not one of the alliance organisations. Yeah.
Maybe we should ask them if they want to be part of the alliance, because they are drug rehabilitation alcohol, and obviously Trevi is quite unique in itself, where they're allowed to keep their children while they're under treatment. So maybe it's a recommendation. I don't know. Maybe it's a recommendation that we ask Trevi if they want to be part of the alliance. I don't know, but anyway, I'm just.
From a contractual point of view, that's quite a lot to unpick in terms of, because that would have to go through the alliance leadership. But I can look into the rationale and how we work together now and feed that back.
It was interesting. The alliance, just to check people can hear, the alliance has been around now for many years, and I think its history was around that kind of collective of the willing that wanted to work together in a different way to try to improve outcomes of alcohol. I don't specifically know why Trevi wasn't invited at that stage, but I guess, Kamal, just to check, that doesn't mean that services aren't engaging in working with them. It was just about, in terms of how the money went for that group of adults, a portion of the money Plymouth spends went to that group of people, which said, you understand these people best, you work together and you shape services that are going to help. So it could be that one of the things that's important to make sure is that we've got the right relationship with Trevi, because you don't have to be in the alliance to not be working closely together. That was just the contractual framework at that time, which I know we are now. We've had the conversations that we're talking about how we move that on in terms of its next phases for the future.
But how I see it is only members that are part of the alliance that get funding. Is that correct? So they might be you might engage with them, but they're obviously not getting any funding. That's my point.
Yeah. So I think we can take that away, Councillor, because as Gary's highlighted, the alliance is a historic arrangement that is very due review. I think we can all agree. So I think by doing that review, we can then undertake the review of the partners in that space. As Kamal said, it's not that straightforward and easy just to reallocate funding, and we have followed a really robust methodology for funding within year and for next, but it doesn't mean that we can't look at whether there are other partners across the city that we may see benefit from being in that alliance space, if the alliance space is the right place for them. So very happy to take a recommendation away from the committee this afternoon to explore that further.
Ray.
Thank you, Chair. You spoke about the action plan earlier on, the local action plan. Does that differ greatly to the national plan?
So the national plan is a strategy. So in a sense, it's our local operationalization of that word. Operationalizing the national strategy locally, and including our local priorities into that, or building our local priorities, adding on top of that, so that it's doing both. And then the action plan is a much more granular. This partner will do this, etc. Which obviously isn't in the national strategy, which sets the broad kind of themes and ambitions.
Lauren?
Thank you, Chair. This is really interesting. I wish my brain was like a little bit fresher to properly go into it with you all. My question is around opioid use. I was surprised to see it as prevalent in Plymouth as it is within the report. So as a result of that, I was then wondering around its impact on the nighttime economy, its any instances we might see of people overdosing in those spaces. If that is something that is reoccurring or something that is of a concern, do we have any kind of community-based naloxone or Narcan in those spaces with kind of frameworks and training in place to help utilise those at a community level? I hope that makes sense as a framework for a question.
I'll hand it to Jenny, who has kind of led our harm reduction work.
Hi, thank you for your question. Yeah, there are a number of things that we've got in place in relation to the nighttime economy. So we have funded a peer project called the Naloxone Advocates Plymouth. They are, within the last year, have become their own CIC in their own right. So they operate, they've got their own board, and they operate under their own kind of their governance systems. As part of their provision, so they are a group of peers that have got lived and living experience of drug and alcohol use. As part of their provision, they have trained and supported with the supply of naloxone to people that are like door staff, for example, taxi drivers, and have done quite a lot of work with the Best Bar None organisation as well within the city. And we also have, with the legislative change in terms of how we can, in terms of who can provide naloxone and who can hold naloxone, we've also got naloxone in our probation delivery unit, we've got it in Shekinah, we've got it in our drug and alcohol treatment services, we also have it at Trevi, so there are a number of spaces, and we also have it in pharmacies and GP practices, so there are a number of spaces across the city that have got naloxone provision, and there are a number of organisations as part of the nighttime economy that are able to administer it as well.
Just a couple of quick ones. You've got in the list here that these go through the MCDA. Yeah, I don't really understand that, but it looks as though you look at that, their criteria. Yeah, the three organisations at the bottom haven't, yet they still get money. Do they still get money, but they don't have to go through that process, which is the HIS, I think one's called, an IPS and the PCC?
Yes, so so those were contracts that we already have in place. So the effective others contract is to support people who are like family members of people who use drug and alcohol. So it's kind of a preventative contract. So these are kind of, and the housing support is obviously a key early intervention. Providing housing support as well is important in terms of that. So those two are existing contracts that we had. So the multi-criteria decision process was only for the funding, which used to be the grant, but is now the additional grant, the DATRIG additional grant that they gave us after the drug strategy, but is now being combined. So the multi-criteria process was to decide that, and then everything else on there is around the was existing. There's existing contracts already in place, so we couldn't change those. Therefore, we couldn't.
Your contracts come up yearly?
Not these ones. Well, not in the time frame for this. No.
So how often do your contracts come up?
It can vary. So these ones, I don't know the exact dates of these ones because they're actually public health contributions to contracts held in other parts of the council. So they're adults, and they're within the housing or the adults world contracts, but we provide additional funding into them because of the public health importance.
I don't understand what you're saying really. If they're supplying something for this type of drugs and part of the drugs group, the organisation,
yeah.
So everybody goes through that except for these three, and surely they're vital to your rehabilitation or your roles within helping the people that's on drugs. So because they're already in there, and you come up with a new group, they don't have to do it. Is that what you're saying?
There was 2.8 million of funding that we had that was not in a contract already.
Yeah.
So that's what the multi-criteria decision process was for the money that's essentially uncommitted because it's not in a contract.
But you're all following the same process, aren't they? Except these three down here don't have to follow it because we're already in.
And it's the same with, I didn't include it because it's in the text, but the alliance contract didn't follow that same process because that's already in it. So all the things that are already in a contract, they weren't included. No, it was what's the additional money.
The contracts come to an end, and then you must add them to. They must follow that MCDA.
Well, at the point that they do, they will. Yes.
But you don't know when they're going to come to the end.
Yeah. So just to add some context to that then. So as Kamal said, some of those contracts are public health explicit contracts, and we know the end dates of those would be that 27, 28, 29. Some of those contracts are contracts that we contribute to. So we give a financial contribution to a contract that sits somewhere else in the local authority that may provide additional support to those individuals, be that around housing or otherwise. Given your question, Councillor, if you would like, again, we can take this through a recommendation from the committee, but we can provide you with the dates of those contracts if that's helpful. But ultimately, what we are saying is aligning with what you're saying is when those contracts expire or are due for renewal, they will then fall in line with due process.
I'll cover that. That's fine. Thanks very much.
And then just on the IPS, so that was again almost a ring fence and the ring fence and the ring fence. So within our drug and alcohol budget, the government said 151,000 is for IPS. So there wasn't a decision around how much we spend on IPS because it's there.
Yeah. The inspections of you've got so many groups, subgroups, and that. Someone new like me coming into this, I think count 13 or something like that. Subgroup reporting to subgroups, and I thought, hold on, this is a bit so confusing. Now, who do these subgroups report to, and who do you all get round at the end like this and say, right, this is a subgroup that's doing with this? Because I think I've counted at least 13 there, subgroup, and or it must be subgroup of another subgroup, and you all meet together, or they're dealing with that. Do they send you in a report of how they're doing? Because when I went and seen a institution this morning, some of these don't get inspected, like CQC, they don't inspect them, other people's don't inspect them. So I said, well, where's your line? Where's your line here? Because as being an ex-care home manager, I got inspected quite a lot, at least every couple of years. Now, these are not being inspected, so who's inspecting them to give them the money? That's what I can't understand. They don't have inspectors, they don't have an Ofsted, they don't have a CQC, which is pretty, I don't say dangerous, but it's dangerous for them as well as the clients that they're in.
Do you want to talk about the governance process then? So how those subgroups feed into the alliance?
Yeah. So the governance, I guess, in the questions around what's the governance structure for our drug and alcohol system. So there's the alliance, which is the contract, and that brings together housing and homelessness. So that's the contract. And there's an alliance leadership team who work with Plymouth City Council to provide that assurance and to decide how that. There are subgroups to that alliance. There's a housing subgroup, there's a treatment subgroup, and there's a children and young people subgroup. And then those are the kind of topic subgroups, and then there's governance subgroups, there's a governance subgroup, there's
I understand that, but what happens if there's something to break down? What happens if there's something, like I do know I've heard of something like someone might be one person on duty a night in one of the homes sort of thing, which is pretty dangerous. Probably wouldn't happen in a CQC environment. No way it would happen. But it is happening there due to cost reductions, so they have to find budgets. So who's going in there to check that these people are safe? I know you're getting the subgroups and subgroups, but are they reporting to you then saying, hold on, because they all get a report. Most people know what a CQC report is. Do you get something like that? That's all I'm asking.
So I think what you're hearing is some of the services we wrap around these people leading quite complex lives are quite complicated. Some of those services are professionally registered. So, and for example, the Live Well clinical input that goes into that is absolutely overseen through that usual regulatory style and clinical professional practice. So Live Well clinicians that are working with people work to clinical standards because they work for organisations that have got all of that. So they deliver that into those partnerships. The alliance itself is governed through a set of arrangements with the local authority with oversight. Housing providers have their own organisational responsibilities and governance around keeping it. So what the alliance does is bring together a collection of organisations, some of which have their own duties and responsibilities to staff, some of which are CQC registered, some of which are clinically backed. So you've got a whole range of people working with others that come together. The oversight through the alliance governance is how are we working? Are we focusing on supporting the right people? Are we doing that in the right way? Can we adjust ourselves? And are we performing? Are we achieving the outcomes that we want for people? So things like the alliance are complex. Those people's lives are very often complex and diverse. And each organisation that is present in those arrangements has its own duties to its own staff, as well as us as a collective, which does make that quite.
I understand that. Every organisation's got their own policies and procedures. Doesn't necessarily mean that they follow them. Yeah, and especially when it comes to funding, they could say that they're following them, especially when it comes to funding. So, is there if I can go to the alliance, for instance, tap on the alliance on the internet and say, and they have to say, well, this is a report on Hamway's House or whatever, yeah, and this is what they do, and they have done this, just a bit like you've done with yourself, yeah. This is what they do. You say, yeah, that's what we're getting our money. Well, we're getting our money worth here. That's all I'm asking. You know what I mean? And it doesn't seem as if there is. You're saying there's an alliance, and within that alliance, you've got professionals that monitor themselves. Is that what you're saying? Because that's what it sounded like.
No, but I see the point you're making. So I think just going back to the point that Gary's made is that those services that deliver clinical services would be governed by appropriately clinical bodies like CQC, for example.
Are they? Some of them aren't.
Well, they should be. Yeah, Live Well definitely are. But for some of those other services or programs, it would be within the commissioning agreements that they would need to provide assurance to us. But that doesn't mean that we necessarily go in and inspect them. What could be done, though, is if people raise concerns, that would then be raised through the Alliance Leadership Group. And then that would be then managed both through the leadership group of that collective alliance of partners and the local authority. So if we had concerns raised to us, we would absolutely investigate them. But what we don't do is we don't inspect all services beyond those that are already inspected through existing clinical
arrangements. So what basically happens is you're waiting for something to happen or someone to complain, and then you'll go in and do it. That's what it sounds like.
No, because I think the assurance does come through the contract monitoring. So within contract monitoring, there will be an adherence to providing good quality standard of service. But yes, in equal measure of that, we don't inspect them to ensure that, other than the assurances that they provide. But if somebody then did raise an issue around service delivery, then we would investigate that.
I understand what you're saying. I'm just a bit sort of, you know, there's money going out, it goes to care homes, all types of care homes, and you don't get monitored as well as I thought it would be.
Yeah, but the assurance for us is around, as Gary talked about, which is the outcomes and the delivery focus on that. But absolutely, quality is integral to the delivery of those services. But I absolutely take your point.
Uh, just to add, that's not Plymouth specific. So that's, you know, because, you know, I understand the point, but yes. No, but no.
Has anybody else got any questions? Who? Anne? Was it? No?
Maria.
Oh, Maria. Sorry, Maria.
I think rather than having a hypothetical question about a hypothetical care establishment, if you've got concerns, Councillor Riley, you know, bring it to the relevant bodies, and then we may be able to provide that. No, but you haven't given specifics about a specific. Yeah, but if you're trying to knuckle down on a specific answer, and I think it would be better to be more specific of the area. You said you've been to a care establishment today. You want to know what the governance is. Maybe if we had a little bit more meat in that discussion, we could answer.
It wasn't specifically that, it was a general that it wasn't, none of them were being inspected, which I've just found out they haven't. That's my whole point I was trying to put over.
Carol?
Thank you, Chair. I think what Councillor Riley is alluding to is, I think he may be asking, Shekinah is not necessarily a clinical establishment, and you know, homeless missions are not necessarily a clinical establishment. Are they inspected? Are they accountable? Because we're giving them funds. I think that's what he's alluding to. But we'll do some homework on that. But my question is a really nice one for Kamal. Lovely to see you again. Hello. I just read that Plymouth as a whole was 43% successful in treatment, but the government, well, the UK is 47, isn't it? I just wondered if you knew why. Is there anything you know why?
The figure kind of fluctuates. That's the most recent one. It's probably a combination of things, and it's probably a repeat of one of the answers I gave earlier. So again, we have a high proportion of people who use opiates in our treatment than nationally, and those are often the most complex people and hardest to progress. So again, by really having really great access and low unmet need, that can hinder that. And we also have an older and more complex population. So it's likely that kind of plays into it, where actually that's can affect those figures.
Just to second that, I think that's obviously where we could research, you know, which areas are we missing out on maybe. I know we're doing great work on this, but might need a bit more research, you know, which areas could we grow on, yeah?
Yeah. Take that. Oh, yeah. And sorry, Jenny wants to just add to the response as well.
Thank you. Sorry, just to add to that, the that percentage, that 44% versus 47% national, that's RAG rated. So we've got a red, amber, green system on the National Drug Treatment Monitoring Service that we pull all of our information and data from treatment services. That 44% still sits within like a green in terms of that RAG rating. But I agree, there is obviously some areas and challenges clearly within our system and within the population we've got.
Is there any more questions? To be honest with you, I don't think we've probably given this as much justice as I would have liked to because of the time factor. So I'd like to bring this back at a later stage if I could, because I think there's yes, sir.
Sorry, Chair, thank you. I was just wanting to add in on that. If we're doing something where something's being presented to us as a deep dive, can we have that at the start of the agenda rather than towards the end of the agenda when we're a bit more energetic for it as well with the heat?
Right. I'm going to say that we could actually bring this back. I'm quite happy to bring this back maybe as a task and finish rather than on an agenda item, because I think this really deserves to be given it, because it is a big issue within the city, and it's not just, you know, I saw on the report, like, we've had an increase of 54% of children under 18 with drug problems. So I don't think we've probably been able to give it how we should have given it today as a deep dive, because that's what I really wanted. So I'm quite happy for this to go as a task and finish, and any members that want to sit on it, they're more than welcome, but it'll be an extra meeting on top of our allocated meetings. So Alison, Will.
I just wanted to say really quickly that, I mean, I wanted to ask a couple of questions about accommodation and, you know, people with addiction and how these things, you know, and I think unless we can cover that, we haven't really sort of got to where we needed to go in this discussion today. And so all I wanted to say was I agree with you that we need to come back to it. And yeah, I'm not even going to go to my question or anything, you know, but there's stuff to say, I think. Thank you,
Well,
Chair.
Maybe like if we're doing a briefing on the alliance, I've learned bits about it over the time I've been a councillor, but you know the purpose of it and how it gets different organisations to work together instead of all being separate and things. You know, things like that might be quite good to aid the understanding of it.
Lauren?
I'm really sorry, Chair. Just from my own understanding, can you help me understand the difference in capacity and scope between a task and finish group and a select committee?
Okay, so the task and finish group that's all it'll be discussed, will be this item, and it'll be maybe recommendations coming from it. We'll be able to gauge more from it rather than just having it as an agenda item. And I think for me, that's what I'd probably like. Come on, did you want to say something? Sorry.
Just coming very briefly, when you said the increase in young people, 50%, that's mean getting more people into treatment. The need hasn't increased. It's more about actually better access. That's a good thing. That will get more people. And then secondly, I guess the conversation then might need to think about how that relation is with I don't know the name of the committee, the housing committee, because clearly the alliance, if that scope is increasing to accommodation, and the alliance in general, that's a contract held by adult social care with public health input. So how that works together needs to be considered by the committee.
Maybe we could do a joint one, with wherever this sits on that committee, housing. Maybe get a few members from that committee and a few members from this committee, so that we all sit down together and then do what we need to do. Are you happy with that? Yeah. Elliot, can I just, out of what we've done today with this item, can you just, because there was a few recommendations, can we just see what they were, just make sure that we've got them?
Thank you, Chair. So I will review the minutes in full just to make sure we've got everyone, and please add. There was one about looking into the rationale of why Trevi were not part of the alliance and any options to bring them into the alliance. And then there was a request for some more information around the dates of contracts and renewals for the alliance. And of course, then we'd have the recommendation about establishing a joint select committee with the Housing and Community Services panel.
Everybody happy with that? Brilliant, thank you, sir.
Chair, can I just add, I think we would welcome working with whoever you design to chair that task and finish, just to shape some of the scope for that, because as you've seen this afternoon, the remit of drug and substance misuse is really broad, but you've delved into some quite very specific questions. So if you would like to focus on those in a bit more detail for the task and finish, we'll very happily work with councillors to make sure that we get the best value out of the time we have together. Thank you.
Brilliant. Thank you very much. I think what I'm going to do now is I'm going to end it here, because we could go on and on and on. So I'd like to thank Maria, Kamal, Jenny, and Steve for staying, because it's a long day and it's hot, but we'll do another dive on this, because I think it's really interesting, and I think it's really important, because it is a lot of money that we're putting into this this issue. So So thank you all, and I'll see you all again. Thank you.
Thank you.
Right, item 12, action log. Over to you, Charlie or Elliot.
Thank you, Chair. I won't go through them all individually for time's sake. If members have got any questions, I'll take them. There are 2 or 3 on there that were marked in progress that we've actually heard today. That relates to the ICB update. That relates to the complaints analysis. What I will do is update that log with all of the actions from today and then share that with members.
Item 13, work programme.
Thank you, Chair. Welcome suggestions from members on the draft work programme at the minute, which will be confirmed sort of at the agenda set. We've got Learning Disability Services deep dive. Learning from today, that would be a deep dive and probably cover an hour, if not more, limiting therefore how much else you can put on. The carer strategy progress review, dementia care pathway and pharmacy are also listed on there. I would suggest that's probably too much if you're doing a deep dive, so we'd prioritise.
I'm not. Sorry. For me, items on an agenda, I'd rather have one big meaty one than lots of little ones, because you can never dive in. You can never really get into it because obviously you're conscious of time. So, I don't know what thoughts are of other members, but we're always going to have the performance and finance on, but I'm a great believer in, like, if we can do deep dives, and so maybe just have 1 or 2 items on the agenda rather than a big agenda list where it looks good that we've had all of this in, but actually what have we really achieved from it? Nothing, because we've not really been able to really dig into it. So I'm quite happy and open for members to suggest that at any point if they want something put on an agenda. It's open to all of us. It's not just me or Paul to make up an agenda. It's for all of you. It is your committee. So, Lauren.
Thank you, Chair. I had a suggestion for what I think would be one of perhaps a smaller item. It is so hot in here, and just thinking about heat waves in general and the prevalence within the UK, they have a huge impact on health and health systems. So, for example, 2,700 deaths in England and Wales just in May and June alone. South West Ambulances Trust had their busiest day on record last week, responding to 5,000 calls. So what I would potentially like to see is a kind of heatwave response and readiness report come from NHS partners.
John?
Pauline, I do wonder whether we could have something about access to primary care and access to healthcare generally in the next 6 months or whatever.
Elliot will be taking it down, so when we have our agenda meetings, we'll discuss. Well,
I think there was a meeting arranged, was something to do with transitions.
Oh yeah, we're still. Yeah, from children to adult social services. That's still going ahead. I think we're probably finding it very difficult to get members from this one and members from that one. I know there was a problem, wasn't there? So, and it's not gone away. We are still looking at that one.
Learning disability services, I mean, would that be in a related area, perhaps, or? Or is it all those things?
Yeah, go on, Gary.
Well, I mean, there's obviously a Venn diagram subset. Learning disabilities is a bigger thing, but of course, that is a group of people that you often know about as they develop and grow in our city, or some might visit our city. So I think it's not just covered by transition, but it's the services themselves are much broader.
Anybody else? There we go. So, thank you all. It's been really, really interesting today. Some really, really good questions. So, thank you all very much.